and also the Director Clinical Services at Jotia.
That is. Good morning, everyone. My name is Dr. Marcela Ogendo, a Senior Principal Lecturer of Kenya Medical Training College. Thank you.
Good morning again. Yes, I'm saying again because I'd earlier been introduced. Again, my name is Brenda Metobo. I work with HealthStrat as a capacity building advisor. Thank you.
Good morning, everyone. My name is Alois Kiema. I work with Social Health Authority.
Good morning. My name is Hilda Wanjiko from Social Health Authority.
Good morning, everyone. I'm David Yator from Mpisha Hospital.
Kijabe Hospital, AIC Kijabe Hospital.
Good morning, everyone. My name is Dr. Daniel Oinaina. I'm Director Medical Services in the County Government of Nakuru.
Good morning, everyone. My name is Dr. John Modes, CEO of Savannah Informatics. I'm Dr. Elijah Matolo, Old Mutual Health Insurance.
Good morning, everyone. My name is Anne Muthoni, representing AP Insurance.
Good morning. My name is Samuel Otieno Ondiek. I'm the National Chairman, Association of Health Administrators. I work at Kiambu Health Department. Thank you.
Morning. Wambui Barasa is my name, from Social Health Authority. Good morning.
Good morning. Daniel Kafue from the Social Health Authority.
Good morning. My name is Mapesa Nelson from Kmtc. Thank you.
Good morning. My name is Alice Kande, CEO, Kenya National Qualifications Authority. Thank you for having us here.
Good morning, everyone. My name is Dr. Kelly Olwach, CEO, Kmtc.
Good morning. I'm Dr. Samson Kuhora from the Social Health Authority.
Good morning and welcome. I'm Josiah Chiruya, Chairperson, Kenya Medical Training College.
Thank you. We have two of our friends who have just walked in this table here. Just a quick introduction.
Thank you. Good morning. I'm Dr. Kojo Gara, WHO, and I'm here to represent in whatever capacity that is possible for the day. I'm sure you understand that language.
And Karibu. Yes?
Good morning, everyone. My name is Ezra Nochel, Deputy Communications Manager, Kmtc.
Thank you. So let us put our hands together so that we appreciate ourselves with one. Let us give ourselves one, and another one, and another one. Thank you so much and welcome again to this Stakeholder Engagement Forum where we are going to have a discussion on how we can strengthen health insurance for sustainable healthcare access. As you can see from our programs, we are almost welcoming our CEO from the Kenya Medical Training College and our CEO from SHA to just welcome us once again to this event and usher us into the next session. But before we do that, I'd just like to inform you that we will have 4 panel discussions. The first panel will be on policy and regulation, where we will be looking at how we can explore the frameworks and the policies that are essential for sustainable health insurance management. And we can see our panelists as listed in our program. We will then move to the second panel, where we will discuss about personnel capacity, health insurance management, training and research. After that, we'll have our third panel discussion where we'll be exploring more on expanding healthcare access, that is matters quality, accessibility, affordability in provision of health insurance for all. And before lunch, we'll have the last panel discussion where we'll be focusing on digital innovations in health insurance. That is how we can leverage technology to streamline health insurance processes and enhance customer experience. So before I welcome my boss, Dr. Kelly Oluoch, who is the CEO of the Kenya Medical Training College, I'd just like to invite our choir to give us one piece so that we can warm ourselves up even as we start. So as they walk up front, I'd just like to inform us that our restrooms are upstairs. When you walk up, you just go straight to the left. Before you exit, that's where we have the gents and the ladies. When you walk up, you go to the left side. So karibuni sana our students from the Nairobi campus.
Kmtc Kenya, chuo cha kipekee cha afya Kenya. Kmtc Kenya, chuo cha kipekee cha afya Kenya. Chaendeleza masomo kote nchini Kenya, vitivo mbalimbali. Chaendeleza masomo kote nchini Kenya, vitivo mbalimbali. Ukienda Nakuru, Kmtc tuko namba moja. Ukienda Mombasa, Kmtc tuko namba moja. Hata huko Hola, Kmtc tuko namba moja. Wauguzi wote tunawapa heko kwa juhudi zenu. Wauguzi wote tunawapa heko kwa juhudi zenu. Washikadau wote tunawapa heko kwa juhudi zenu. Washikadau wote tunawapa heko kwa juhudi zenu. Universal healthcare inapatikana kote nchini Kenya. Universal healthcare inapatikana kote nchini Kenya. Hata Asha Kenya, hata Asha inapatikana kote nchini Kenya. Ukienda Kisumu, Kmtc tuko namba moja. Hata huko Hola, Kmtc tuko namba moja. Hata huko Lamu, Kmtc. Hongera, 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 chuo chetu cha afya. Chuo chetu, hongera, 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 oh, hongera, hongera, chuo chetu cha afya. Namba moja, hongera, 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 oh, hongera, hongera, chuo chetu cha afya. Namba moja, hongera, chuo chetu, hongera, oh, hongera, hongera, chuo chetu cha afya. Na wizara, hongera, oh ya afya, hongera, 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 wizara ya afya. Wizara, hongera, 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 oh, hongera, hongera, wizara ya afya. Serikali, hongera, 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 serikali ya Kenya. Serikali, hongera, 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 oh, hongera, hongera, serikali ya Kenya. There will be more. Once you get like we'll go.
Thank you so much, our choir director. Let us give them one. Let us give them one, and another one, and another one. Thank you so much. So to our board chair, the Kenya Medical Training College, kindly allow me now to welcome the CEO, Dr. Kelly Oluoch, to just welcome us. Because from our program, we can see that we have a session for remarks in the afternoon. So for now, he's just welcoming us, being the host to this event. Then we can proceed. Karibu sana, Daktari. And as he comes, we can give him one. Let us give Daktari one, and another one, and another one. Asante sana.
Thank you so much, CCM, the board chair, various CEOs who are here, representatives from private health insurance organizations, our partners from the counties, our partners, our students, good morning. Good morning. Before I give my comments, I want to invite the chair of the board of directors, Kenya Medical Training College, Mr. Josea, to say a word before I give my comments. Karibu, Chair.
Good morning. I'm aware that we are ready to interact for this session. We have a lot to hear from our experts. My sole assignment is to welcome each one of you to this important session. Kindly allow yourself to concentrate. You can put your phone in the silent mode. Tell your friends that you are engaged. You don't have time for them for this day. Concentrate with what has brought us here. Kmtc is number one. You've heard from them. You're also number one where you are. So as Kmtc, we have a succession plan. You've seen we brought the students so that they can learn from you. So that when you retire as experts, they take over from you. Thank you very much. God bless.
Thank you, Chair of the Board of Directors, Kenya Medical Training College. We are here gathered for a very specific purpose, to have discussions concerning medical health insurance. And you know, as a matter of fact, that we have pillars that support healthcare. Among those pillars that support healthcare, health financing is very key. Among the pillars that support healthcare, we have what we call human resources for health. These two pillars, for the success of the health insurance and the SHA that has been rolled out in the recent past, we must make sure that we align our activities to make it successful. All of us here have helped in one way or another to make sure that we have success in the rollout of SHA and in medical health training. We, as Kenya Medical Training College, have a critical role to play in ensuring the success of SHA. In this endeavor, we, as Kenya Medical Training College, have worked together with industry players, that is the private medical insurance organizations, SHA, and other players, to make sure we have a course that supports the rollout and sustainability of SHA. This is going to be very critical in ensuring that even as we roll out SHA, as we talk to the public, we have professionals that are guiding, supporting registration, claim management, and making sure that we have efficiency in the operations of SHA. We have the spirit of one government, as the President has consistently said, that each sector must find a role in ensuring that bottom-up economic transformation agenda is successful. For it to be successful, the pillar of health is quite important. And that is why we have gathered today to make sure we have deliberations that support us to make sure that we have conclusive resolutions that will go forward in ensuring we have a successful rollout and we have a successful human resource capacity, or what we would call nowadays human resource capital, that is key in ensuring the success of these endeavors. I am very, very delighted today that the invites that we gave have been honored. All of you who are seated here, it is an honor to us, Kenya Medical Training College, that you made time to come and join us in this discussion. We would want to engage with everyone. We want to give a listening ear. We want to make sure that the resolutions that come out of this engagement are used to be incorporated in our processes to ensure that we infuse efficiency and effectiveness in training and in the implementation of health financing in Kenya. We do not take it for granted that this morning you have given us your time. We know that you have kept away your busy schedules to come and engage with us. And therefore, I want to say that as we engage, let us ensure that we give our best observations. Let us ensure that we give our best comments that would help us to build a better system, a better human capital, a better health financing that then would go a long way in ensuring that the citizens of this republic have embraced universal health coverage. It is therefore my pleasure to welcome all of you to this activity this morning and part of the afternoon to engage each other, to talk to each other, to learn from each other, and to make sure that we have resolutions that we can use to take this conversation forward towards implementation. We are also privileged in this meeting to have the representative of CEO SHA, Dr. Kuhora. I know we have worked together previously, and now I'm also excited to see you again. I want to invite you to give your comments as we start this session. Karibu, Daktari.
Good morning once again. First of all is to appreciate the team that has availed the time to be here, to look at what roles we can play as far as the current agenda of achieving UHC through health insurance is concerned. I know there's been quite a lot going on in the recent past. Part of it has been called misinformation, part of it has been called disinformation, part of it has been called lack of information. I hope the sessions today will be able to provide a good highlight on the why, the how, and what is meant to be achieved, because at the end of the day, we are looking at the outcomes. In one of the engagements that we've had with the Kmtc team earlier, one of the issues was how do we support the 4 pillars that have been proposed to support UHC in the country. And I think one of the things that came up strongly is that the knowledge gap when it comes to the HRH is quite strong. Therefore, we need to have initiatives to support that and have it being done. And I'm glad to see that there's actually a team that is being trained on health insurance management. The other thing is to appreciate the other stakeholders, because more often than not, NHIF as it was, or SHA as it is, was seen as a government project. But we've made deliberate efforts to engage stakeholders across. And the participation is actually very welcome. And the main aim is to get to a point where we can say for every million shillings that we are spending on this particular benefit, these are the number of lives that have been saved. This is the quality of life. The quality of life has improved by X%. When it comes to longevity of life, we can say that we've improved the life expectancy by X% by spending this kind of money when it comes to healthcare. And from my perspective, and for the people who've studied health economics, it will be good to get to a point where we can say that, or we can come up with a conclusion that health is not an expenditure, health is an investment. And if health fails, basically everything else is likely to crumble. So welcome and thank you.
So thank you, our board chairperson, the board chairperson of the Kenya Medical Training College, the CEO of the Kenya Medical Training College, and Dr. Samson Kuhora representing the acting as CEO at the Social Health Authority. So let us give them 3 again for those opening remarks. Let us give them the first one, and the second one, and the third one. Asante sana. So we are now transitioning into the first panel, and I would like to invite our moderator, Mr. Joseph Otieno, who is representing Dr. Zainab Gura, who is the acting DG at MOH. Please take a seat here on this table to the right as our moderator for the first panel discussion, and I will invite Dr. Samson Kuhora, who is representing the acting CEO at SHA, to take the seat on the left. I will also welcome Dr. David Kariuki, who is the CEO at the Kenya Medical Practitioners and Dentist Council, to take the next seat to Dr. Kuhora, so that we start our discussions on matters policy and matters regulation. Dr. Kariuki, welcome, and take a seat on the table on our left. Karibu sana. And I will now hand over this mic to Mr. Joseph Otieno, who is the leading benefits design at the Social Health Authority. So we can give them 3 factorial, even as Bwana David prepares and as Daktari settles in, so that we engage. So let us put our hands together for 3 factorial for them. 1, 2, 3, start. 3 factorial, we start with 3, then we do 2, we do 1. So let us put our hands together for 3 factorial for the first panel. So 1, 2, 3, start. Thank you so much, and karibu.
Okay, thank you. From the program, we were expecting 4 panelists, but we have 2. So I think that will make us move faster. So generally, we know how the impact of sustainability in terms of the benefits is concerned, in terms of both the private health insurance and also UHC under the government. So I think my first question will go to Dr. Kuhora, and it will be in line with how can health insurance models balance financial sustainability and at the same time ensure they provide adequate coverage within the benefit package?
Okay, thank you. That's a pretty long question, but I'll seek to be as brief. Countries can adopt to finance their healthcare provision. There are several other ways that other countries have used, but this is one of the ways that the countries use. There is also a provision that a hybrid method can be used. I think in one of the forums that I was in last week, there was an issue that was raised on what is referred to as policy mimicry, where you assume that what works in country A will also work in country B. So one of the things that is done is that we have to look at our environment and look at which policy best fits our situation. So in what has been adopted, it is social health insurance, and it's a mix between the insurance bit, which is contributions, and a tax-based financing for the primary health care and also for the emergency, chronic, and critical illness. Now, in our environment, and why, probably the logic behind why this has been used, when we look at our population, we run the population using the estimates that were provided by the Bureau of Statistics, about 13.89 million households. And of this, there is a proportion that is in the formal sector, about 17% in the formal sector, the rest in the informal sector. Of the population that is in the informal sector, there is a significant proportion that does not have regular income. So now, the next question is, what do we do about it? So what has been proposed is that for the primary healthcare services, there is a tax-based financing. For the social health insurance, which is basically the contribution-based, several things have to apply. And one of the key things that have changed is to use the ability to pay and to also look at the level of equity that is achieved when it comes to the ability to pay. So ability to pay basically means that the population that is able to raise a higher premium for their medical cover is enabled, and that is what is applied when it comes to what they contribute to the social insurance pool. And that's why at the moment there is a standard percentage that is being used across, as opposed to how it was before. Then the next bit is to achieve a good level of equity. Now, to achieve a good level of equity, there are several things which are usually done, but in our case, we've used a standardized approach. There are countries which used a more progressive, a progressive kind of financing, where the more you pay, or rather the more you earn, the more you pay in terms of a percentage. But for us, we've used a standard rate as probably the starting point. Maybe over time, some things will also change. The next bit we consider is how much is the risk? Because for you to apply the principles under insurance, you're basically insuring a risk. So if the risk is 100%, then that means you have to have 100% of the reimbursement for that service. Otherwise, sustainability is going to be a problem. So the next thing that we look at is what is the risk. To estimate the risk, you need to know the population. You need to know the disease burden across different sections of the population. And as I said, we cannot mimic what is there in Netherlands. In our environment, we have an unmet healthcare need. So we have to estimate that unmet healthcare need and look at that risk. Because from the estimates that we've run, is that there are populations in the country, just as an example, they are living with a hernia not because they don't know about it, not because they don't know there is an intervention, but because even if it was there, they would not be able to afford it. So the moment it is availed, and there is a financing mechanism, either using the social insurer or the tax-based financing, they are going to present. So what happens? We are going to have a spike, a significant spike in the early phases. Of course, there are those who are curious just to find out whether it's working or not. But then there are actually those who need that service, but the reason why they've not been accessing that service is that there has been an unmet need in the population. So in our environment, we appreciate that there is that population, and therefore we also adjust for the unmet need. So the risk that we are seeking to undertake using the insurance perspective is the population multiplied by the service need that is available in the country. There are other areas which we have to adjust downwards. For example, dialysis. From the estimates that we have, the dialyzing capacity in the country is lower than what is needed. So even if 100% of the population showed up, we still know that there is lower than needed investment in providing the dialysis center. So we have to make all those adjustments, and then that is what informs the insurance risk. Once we do that, we look at the yield. Where is this money coming from, and how sustainable it is? Once we make those projections, then that is the point at which we can say that this is the insurance model, these are the premiums, these are the risks that we are undertaking, and this is the population that we are likely to reach out within this period of time. And that is the approach that we have used for UHC. Thank you.
Thank you, Doc. I'll come in with a rejoinder to that question. You've talked about equity. So there's been a lot of questions about the 2.75. So equity in terms of contribution and equity in terms of access to benefits. Is there a difference between equity when it comes to those two in UHC and then with private insurance, private medical insurance? Thank you.
Okay, equity in terms of contributions. I mentioned that that is one of the things that we've sought to achieve. And just to give you a perspective of the challenge that has been there before, what we were seeking to cure. When it comes to the estimated contributions under NHIF for the poorest earning populations, that is the lowest income band, the average using the mid-income range was about 5%. So that population was contributing 5% of their income to their social insurance. That is the formal sector. When you go to the population that is earning more than 100,000, on average, the contribution was 1.12%. So it meant that the poorer that you are, the more that you're likely to contribute into the social insurance pool. So that, with that, the equity in terms of contributions was not being achieved. And I think that's usually referred to as a regressive type of financing, because the lower you're earning, you're spending more. Now, when we looked at the population that is insured based on the quintiles in the country, or has health insurance in the country, the poorest 20% have a insurance coverage of 3.2%. And most of these are actually supported programs. On the other side, the richest 20% has an insurance coverage of 52%. So for us to be able to achieve some good level of universal health coverage, targeting the whole population regardless of your economic status, some of those changes are needed to be made. I know there's been quite a lot of questions, where did that figure come from? Let's be clear that it was not arbitrary, first of all. Yeah, so what we did is that we looked at the different income bands. There were about 11 of them, and the current contribution status, which was ranging between 5% and 1.12%. Then looked at the populations in those different income bands and did a weighted average. Now, what had been proposed from some of the engagements was whether a cap could be introduced. But then that was not eventually done. So that's how the figure was arrived at. Is it able to support itself in terms of the member contributions? The answer is yes. I mentioned about sustainability. So in as much as we are looking at equity, in as much as we are looking at the risk, we also have to look at sustainability. So those are the provisions that were made. Now, when it comes to access to benefits, the scope of cover that is available under social insurance is available to everybody. And that is how the super cover under NHIF has been running. So whatever cover was available to anybody in the formal sector, as long as they were statutory contributors, was the same to the person who was contributing 500 shillings from the informal sector. Now, under social insurance, that is the same principle that is being applied, that it's the same cover that is available to everybody. So access to benefits is also equated across. So what we've targeted under the Social Health Authority is to use what we are calling a 12-point principle. I think you're aware of a report that was published in 2018-19, the Health Benefits Advisory Panel report, and then another report on health financing sustainability in the country, the Health Report 2019. And from that, we adopted a 12-point criteria. The 12-point criteria basically prioritizes what the whole population needs. So it's not looking at a section of a population and financing what that section of the population needs. It looks at it from a public health perspective. What does the whole population need? And just to put it into perspective, when we look at oncology has been financed under NHIF for about 7 years. But when we look at the data, there are several things that were coming up. One is that when it comes to the scope of cover, it was largely related to the treatment. Now, is that the patient pathway when it comes to cancer care? The answer is no. So when you look down, when you drill down into the data, there are several things that were coming up. Of the cases which were being put on treatment, you are aware of the treatment plan when it comes to cancers. You need to do the screening, you need to do the diagnosis, you need to do the staging, and then you agree on the treatment plan. And that treatment plan is meant to have a particular outcome, a defined outcome. Either you can say that this person is cured, or you have reduced the size of the tumors, or you are maintaining the life of this patient. Now, when we looked at the data, about 63% of the cases of cancer in the country were actually not staged. So only about 37% of the cancers were staged. Of the 37%, 81% were presenting in stage 3 and 4. So with that in mind, it means that there is quite a lot in terms of the cancers. Before you even look at the population of patients who have not been diagnosed, even the ones who have been diagnosed, there's a problem in terms of the staging, there's the diagnostics and the staging, and there's a problem in terms of when they are presenting. So if you look at the current intervention, it seeks to invest in screening, and there's a provision that has been made for that. It also seeks to invest in diagnostics and staging. So that way we can have a more informed way of, this is how we are progressing with the treatment. Now, when it comes to the financing of the treatment, we are looking at financing the treatment plan, not financing sessions of treatment, because there are those cancers which require 20 sessions. There are those cancers which require 6 sessions. So what happens to the patient who needed more than 6 sessions? So we are seeking to move to financing a course of treatment, because it gives you a specific treatment outcome that you are looking out for. So those are the aspects that we're looking at around UHC. Then there was a rejoinder on the role of private insurance, and I'm glad they are represented. Now, I will put it in 3 broad perspectives. How it is envisioned is that private is still going to be there, so it's not something that is going to be phased off. Then 2, it's going to play a complementary role, because there is this cover that is applicable to everybody, and it covers what majority of the population needs, but it does not cover everything. That means there is still going to be an additional role that is going to be played. Then 2, it is supportive. We are all aware that the social insurance platforms, they have their own limitations. So the commercial insurance plays a supportive role in terms of covering the population, and also broadening the scope of cover when it comes to the health insurance. And then thirdly, as we've had actually quite a number of engagements in the last 2 years with the commercial insurance, is that there are joint roles that are played by both. I think you are aware that medical fraud is one of the key challenges that we've been facing, and collaborations with the private insurance sector is one of the ways in which we can be able to address the challenges that are there as far as medical fraud is concerned. So that's how I would approach the collaboration.
Thank you, Doc. I'll move to Dr. Kariuki. So the first question generally will be, what are the challenges you're facing as a regulator in terms of looking at medical sustainability for health insurance in regards to healthcare providers? Thank you.
Well, thank you very much, and good morning, everyone. I would look at it probably from several angles. One, regulation is a product of policies. So for sustainable health insurance, one of the key things is that we must have, policies that would make, health insurance be implemented in a manner that is beneficial to the intended populations. So when we talk of policies, one is, insurance policies. Like, do we have a national insurance policy that guides on how we shall be able to attract people into, into the large pools so that we can be able to cover them? Because when you look back, and I think Daktari has just mentioned that the insurance penetration in the country probably is currently at about 3%. So meaning that 97% is still out there, not covered in any form of insurance. And therefore that creates a large problem for us as on the regulatory side, because then it means you'll have a large pool of people that are not covered and therefore not able to cater for their health needs when these arise. So an insurance policy then becomes quite critical. But I think if you look at the country currently, there are efforts to make sure that we get more people into the health insurance and be covered for when needs come. Remember, the policy then now is what determines the way that it will be taken. There are two ways, largely, whether it will be voluntary or it will be mandatory to have health insurance. In this case, when you look at the motor industry, it is mandatory. It has been mandatory from the beginning that you must have some form of motor vehicle insurance, whether it's third party, whether it's comprehensive, or any other. In the health sector, it has been voluntary from independence until last year, when the Social Health Act was passed. And now it is mandatory that every Kenyan must be on health insurance based on their ability, and then access health service based on need. So, and I think that is one of the ways that we can make health insurance sustainable, because we have a large pool of the whole population. When you talk of over 50 million people, everyone contributing as per their ability. So one of the other key things is that, yes, even when we make insurance mandatory, for example, or when it is voluntary, then you must have policies on how you are going to collect these funds and then pool them and then be able now to purchase the services from the provider. So these policies now then help us to make the regulations on how we are going to make it sustainable for us. You may have the money, but if you don't know what you are going to use it for, then it becomes a challenge. That then makes it necessary to have policies on health packages, like has been already mentioned. Then what are we going to spend the money on? So what are our most critical needs, and how do we allocate these monies to the various categories of illnesses that we may have? Remember, health needs are infinite. If we were to be asked, we would want to cover everything. But resources are finite. We, at any given time, only have a particular or a certain amount that we can use. And it is that amount that then we must prioritize to be able to know how best do we cover our population for the current needs that we have, so that we do not have an increase in our morbidity and mortality. This then brings in the issue around our policies, guidelines on clinical care. What pathways will people pass through? So that when you have an illness, you do not start with the highest level of care. You must start from the basic. Then in that pathway, if your needs are sorted at the basic level, then you may not need to go to the higher level of care where the costs are higher. For you to sustain your insurance pool, you must then make sure that people get access to services at the level that is appropriate for them. So if it is screening, not necessarily, let's say, from a level 6 facility, right? It can start from the lower level, basic primary care for screening, so that those who go to the higher levels of care, where costs are higher, where the level of skills are higher, are only left to cater for those who need. Regulations come from those policies. Now, you then find that other policies that we may need are, the kind of economic policies that we have that will determine the way taxes will be, collected and then allocated to the various needs, in this case, to health insurance. Because as we get to know who is going to pay and be paid for, there are those who will require support within the population so that we get the pool. And therefore, the policies may also require to have incentives so that we can, voluntarily pay according to our needs. I'm sure one of the challenges my colleague is having here is when doing the means testing, people may try to maneuver the system to pay as little as well. I'm not saying that's what's happening, but you know, from across the world where means testing happens, you may get such issues. So you find that for us as regulators, we base our regulations on evidence base. So which may cause a strain on the insurance, because if we say a certain illness is meant to be treated in this way, it has an effect on the insurance, because as they purchase, and we say for this type of illness, say cancer, this is the clinical guideline for it. And you may find that that treatment is very high. So they have to, you know, now package their payments based on the available evidence. So you cannot say you are going to give lower quality care because you had less money. You have to give the highest level of care. And so then our packages must be measured on care. And now the issues of co-payment start coming in if we are not able to collect enough. So our health insurance systems must be able to collect as much as possible to be pooled so that we address everyone's need. But remember, it's not a one point in time thing. So these are things that keep coming over and over and over again. And I believe the colleagues in health insurance then have to keep refining their packages based on our economic situations and the ability to keep pulling more and more money, so that as we pull more and more, we are able to keep revising our packages in terms of what can be added. Remember, again, within health insurance, it must also look at when evidence changes in terms of management of certain illnesses. It may mean that the package may be changed because the new way of treating may have either become more costly or even better. When it gets cheaper, it gets better for all of us because we are able now to add more items into our health insurance package. So basically, policies and regulations that come out of it must be made in a manner that is going to be, you know, responsive to the needs of the population. I think I would want to stop there for now. Thank you.
Okay, I have a follow-up question on that. You have mentioned clinical guidelines, and the follow-up question is in relation to the issue of supply-induced demand and adverse selection. So what is Kmtc doing in terms of regulating supply-induced demand? Thank you.
One of the things that we do in regulation is have what we call scopes of practice. One, that helps to ensure that everyone who is providing care based on the highest level of knowledge and skill that they have. The other thing that we do within the regulation space then is to have what we call codes of ethics and have something people don't like so much, which we call discipline and ethics, so that if one goes out of the line for which they were trained for, then we have mechanisms of objectively getting them to understand that there is somewhere they have gone off the way and they need to get back. And sanctions or rewards may be put in place to ensure that people do no harm, because what you are trying to say is that sometimes people may be tempted to go beyond what they are supposed to do, and that may cause harm. Because once you induce a certain treatment that you know was not necessary, basically you are getting somebody into some form of harm. Because you may lead us to antibiotic resistance, you may lead us into long-term complications of some forms of treatment. So those are the mechanisms that we put in place to try and ensure that people get to do only that which needs to be done and do no harm. Of course, the other thing we do is to work with the insurers, in this case, like the Social Health Authority and its predecessor, so that if they detect that there is something that is going on, we work together to either get that, if it is a facility or an individual health professional, to be advised not to take that route. Advices are of many kinds. Maybe, yeah. Thank you.
Okay, thank you, Doc. I think I don't know how much time I have. Oh, you have your mic. I'll come back to Doc. We know the government looks into subsidies, especially for those who are not able to afford premiums, so that they also be able to support it to have medical insurance. So what role do these subsidies play in sustainability of health insurance, especially UHC?
What roles do the subsidies play? So first of all, let me just give a perspective of paying premiums or contributions for informal sector contributors who have been identified by the Social Protection, State Department for Social Protection. One of them have been the health insurance subsidy programs. One was targeting the orphans and vulnerable children. Category 2 was targeting older persons and persons with disabilities. There was the UHC project that was launched targeting 1 million households. So the government has been paying premiums for them so that they can enjoy the health insurance cover. Now, moving forward, I mentioned that when we are estimating the risk, we also look at I mentioned that when we are estimating the risks, we also look at the yield before we decide that this is what the yield can be able to finance. And from the population dynamics that we have presently, and this is just data that is available in the country, about 16% of the population is considered extremely poor. So even making that contribution will be a challenge. And even if we are charged with the role of doing means testing and collecting revenues from them, it will be incurring an admin cost trying to raise revenues from a population that we know inherently will not be able to afford. Then there's an additional to 12% of the population which is considered food poor. So this population is going to be making a choice. Do I pay for my health cover, or do I buy the next meal? So the probability that you're going to get some good or some reliable source of revenue from this population is low. So these are the two main categories of the population that actually require government subsidies. And from the population dynamics, that's about 28% of the population. Now, if 28% of the population is not able to afford and they're still accessing the services, then sustainability is going to be a concern. Then the next bit is, what is the likely disease burden in this kind of or on this population that is likely to be poor? What services are they likely to need? And from the estimates, there are the populations that actually utilize in terms of the hospital visits, they generate most of the visits. And in terms of the costs, they are low to medium. The main reason why they might not be able to accessing the high cost ones is because they might not be able to afford the out-of-pocket payment or the commercial insurance that is supposed to supplement it. And just to put it into perspective, I mentioned about oncology, so allow me to continue in the line of oncology. From the data that we have over the last 5 years, about 63% of the cost of oncology were having to be met out of pocket. So even though we were spending quite a lot in terms of supporting the cost of care, about 63% of the cost was still being met out of pocket. So that means this population, which is entirely relying on their income or on their what they have in terms of assets to be able to dispose and access care, would not be able to access the more expensive forms of intervention. And that becomes a challenge because that is the population that ends up being burdensome to the healthcare system. So that is the reason why this population would require subsidies, just so that they can be able to access healthcare and actually access the whole scope without having, without it being too expensive for the authority to be able to raise that revenue, or the population actually significantly suffering. Now, there's still another section of the population, about 7%, that is teetering. I think you've been hearing of catastrophic expenditure. It just takes one disease, one expensive disease, and the population goes back into poverty. So that's the population dynamic that we use, and that is what we use to request for subsidies from government so that this population can actually be insured and reduce the aspects around non-sustainability of financing their healthcare.
Okay, thank you, Doc. I'll go to Dr. Kariuki, and then maybe we'll have one question from the team. So, Doc, we know there's a very big challenge in terms of the rise in disease burden for non-communicable diseases. So at the same time, we know there's a challenge, especially in private insurance for coverage for the aging population. So how can insurance systems prepare for this change, in especially demographics, and then in terms of the disease burden? Thank you.
Yeah, thank you. Yes, it's true. We are faced by a threat of increases in disease burden, especially the NCDs. And I think one way that health insurance or insurance in general may be used to address and respond is that within the packages, it is very critical to have wellness as part of the package of services being provided, because I think the best way to manage and assure us that what we have available will be enough is by keeping the healthy, and those with illness, we prevent complications. And so I think within these packages for the private insurance and even other insurance, it will be critical that part of it be mandated that wellness is part of the package of services. And I think if even incentives were to be added that the healthier you keep yourself, next year you can get some discount on the premium that you pay, probably would help to make, I don't know whether that would be possible, but it may help address the rising burden of disease. I think in summary, that's what I may want to say on that. Yeah, thank you very much. Yeah.
Okay, thank you, Doc. I think maybe we can have one question from the audience, and then we can wrap it up.
Thank you for the insightful discussion. So my question is to Dr. Kariuki. I think a lot of times when we talk about quality from a regulatory perspective, it largely focuses on the structural aspects of quality, so that process and outcomes almost never feature. And that reflects also in what Dr. Kuhora mentioned. When you talk about 63% of cancers being treated without staging, or at least without that information being there, what role do you think you can support to make sure that there's actually adherence to clinical guidelines based on the latest evidence? Yeah, because that seems not to be there at the moment. I think everyone just does whatever they want within the health system. Thanks.
Thank you, Doc. I think you can take that.
Thank you. Yes, quality is one of the most critical aspects of care, and actually is one of the ways that we can use to sustain the insurance, because if we do the right things in the right way, then we get to better solutions faster. So what we are doing, and we are actually working with them, you realize if you are health providers, and health provider could be a facility or a person, whereas previously we used to use what we call level of care to determine your pay or the amount of money a provider will be paid. Now we have moved from saying you are just a level 4 or a level 5 or a level 3 or a level 2 to paying for the service you actually provided. And for you to stay on will depend on how best you keep providing that service. So these are changes that you will see in the very near future when it comes to that it's not a bundled payment, that it was a level 4, so just pay it. It is what did that level 4 do? It provided treatment for malaria. Then it is paid for the package for malaria. And there will be checks to go and confirm, because even now what we are doing is that when we say we are providing malaria, it means that you have all the resources to provide treatment for malaria, as an example in this case. That means you are able to triage, you have the human resource, you have the diagnostics for it, whether it is lab or radiology, depending on the illness, and then you have the medicines to treat. That is what we are calling a package. So if you cannot provide that full package, then we are not going to say you are providing that service. So what currently we have with the Social Health Authority is that from our system, we are able to tell them, this facility, these are the services that they are able to provide. But remember, the service that one provides today is not necessarily that they will be able to provide it tomorrow, either because machines have broken down, staff have exited. So this will be a continuous process. And most of it is going to be done in a manner to help the facilities improve on the services that they provide, not in a punitive way. It is to help them be able to continuously improve the services that they provide for the benefit of the people they will be providing in the network that they shall be in, because we are informed that now they will be formed into networks, so that if I don't manage to get a service in facility A, I can go to facility B and my treatment is continued to the extent that I'm able to be provided with all the needs that I would have required for the current or that illness that is being treated at that point. So yes, quality is going to become the bigger issue rather than just having a license to operate. Thank you.
Thank you, Doc. I think we're on time. And we've had a very good deep dive. Oh, you have a question? Maybe we take the last one.
It's not a question per se.
Okay.
My name is Ken Nauma. Allow me to give industrial perspective with regards to cancer, and then Dr. Kohara will then advise. Now, this is what happens in oncology outside here. Staging is done by Kmtc. Kmtc is here, right? And by last year, I think we were 2 years behind schedule in terms of staging. So, and we have less registrars who are doing data registries in the hospitals. So with Kmtc here, with Kmtc, with Kmtc, with SHA, now the industry staging is done at Kmtc, not at the facility. If it's done by the facility, there are not enough registrars to do that staging at the facility. So do we have regulations to help us with cancer staging? Number two, would Kmtc then train the registrars for all the hospitals so that they can do the staging? Number three, would Kmtc agree to be assisted by WHO in terms of registrar training? Thank you.
Good question. I think that we'll have a comments from both Dr. Kohara and Dr. Kariuki.
Thank you. That's actually a very good perspective of exactly what ails the bit around the staging, because what we do from our side is we look at the data and make decisions, because at the end of the day, a benefit is a progressive thing. It's not something that it's static. You look at the data, see what is working, what is not working, what is inhibiting its sustainability, and then propose an intervention for it. So one of the things that on our side we needed to do was this, invest more in the diagnostics and the staging, so that you remove that financial barrier for this person who the staging will be needed, but because the financial barrier is there, they cannot be able to afford it. Now we are on the second stage of now, or rather we've put in some resources, put it as a provision, looked at what has been recommended when it comes to the most common cancers. Let's start from the first 4. Then the next question is, how do we do it? And that's the engagement that we're having with the regulator. Which labs do we recognize? Which professionals need to do that? Who are the persons who take responsibility for whatever is provided for? And then we handle the reimbursements from our side, from the financing perspective.
Thank you, Doc. I think, Doc, you can have your comments on that, and then.
Well, maybe there are not much additional comments, but I think just to work towards improving our capacity to be able to register stage, at various levels, remembering that we are in a devolved system. It is better that we keep increasing our capacity to be able to take these services as close to the people who need services as possible. Thank you.
Thanks. I think we wrap it up. So we have done enough in a short time. So kutupigia tu makofi. Thank you, Dr. Kariuki, Dr. Kora. Thank you so much. I think you can have a seat.
Asante sana. Thank you so much, Bwana Otieno. Thank you so much, Dr. Kuhora. Thank you so much, Dr. Kariuki. So as they exit and as we prepare to receive the second panel, we can give them 3 again. Let us give them 1. Okay, let us give them a better one. 1, and another one, and another one. Thank you so much. We now transition into our second panel, and I would like to welcome our Deputy Director at the Kenya Medical Training College, Madam Dr. Nyawera Mwangi, to take the seat at the center here. Then I welcome my CEO, Dr. Kelly Oloch, who is the CEO of the Kenya Medical Training College, to take the seat next to the DDA. Thank you so much, Dr. So we welcome Dr. Kelly to take the next seat on the left of the Deputy Director in charge of academics. Then we welcome Dr. Koja Ogara from WHO to take the next seat after the Kmtc CEO. I'll also welcome Dr. Alice Kande from KMQA to take the seat on the right of our Deputy Director in charge of academics. Dr. Kande, take the seat here. Thank you very much, and I'm informed that one of our panelists is on the way coming. So karibu sana daktari, and take it over. You're going to take us through the session on personnel capacity, that is health insurance management, training and research. Karibu sana.
Thank you very much, and I welcome the panelists, and thank you, team. I know you'll have quite a number of contributions to make, so please, if you have a question, you can already pass it to me here, pass it forward, then I will be able to ask it for you. But I thank you, our team, Dr. Kojo, I really thank you, Dr. Kande, I thank you, Dr. Kelly, I thank you. We're going to focus, we are focusing on health insurance, and in the previous session, Dr. Kohora told us that health is an investment. Now, is health insurance an investment? If so, how? How is it an investment? So I'll be asking those questions. I'll begin by asking Dr. Kojo, does health insurance improve health outcomes?
So, good morning.
Morning.
I think in all fairness to support this discourse, for today, with all protocols observed, everything that you would need me to address needs a consultative process.
Mm-hmm.
And if I do make a commitment here, it means I'm making a commitment in terms of WHO Global.
Mm-hmm.
Because this is our first meeting, all right? On behalf of WHO, kindly do let us hang back for your consultations on WHO today and your responses. And for the next round, when you do call us for the meeting, please do let us, have the full support of how exactly you'd like us to come through. It would be unfair to close out on behalf of WHO without protocols being observed. I'm sure we do understand that. Could you allow me to do that for today? But as I sit in front of you here, I have listened to, including some queries from the previous panel and from what we need to discuss today. And I'm happy to commit that we will come in and have a bit more of an informed discussion on a panel for the next round. I did explain to the director of comms as well and the conveners as to why we would take this position today. Yes. Would you allow us to do that?
Yes, we will. Thank you for those remarks. Thank you also for coming in. And our apologies for any protocol deviations. We would really want the input of WHO in very many things. And therefore, we will we'll follow the protocols to ensure that you are able to contribute.
No problem. And this is just an opportunity to make the commitment or bold statement that I'm here because WHO is interested. But we follow a highly consultative process. And so we are happy to continue the discourse.
Okay.
Yes, do not take it as
no problem at all.
a refusal or a lack of commitment to do so.
Okay.
Yes.
Are you able to comment in your private capacity in the discussion?
It won't be because I'm wearing everything WHO. So we will break the protocol that, also puts you in some light when questions start being asked, yeah?
Okay.
But please do let me have everything you would like WHO to support because health financing is a key pillar that we are doing.
Okay.
Into the next discourse.
Yes.
And HRH is also quite part of it.
Yeah.
Yes.
Thank you.
And so there's opportunity for all of us.
Yeah.
There's nothing that has happened wrong. I am just not able, as of this first meeting, to commit on behalf of WHO.
Okay.
Yes.
I thank you. I thank you. No problem. Yes. But just continue sitting there, but it's okay as we discuss.
I'm here to honor everything as of requested as of this meeting, except to make any commitments on behalf of WHO right now.
Yes. No, we will not ask for any commitments.
Yes.
Yes.
All right?
Yes.
And on a personal capacity, I am able to.
Yeah.
But I wear WHO as of this meeting.
Yeah.
So it will be taken out on international space as of WHO.
Okay.
Yes, and it will be very unfair for your discourse if it stops at some point.
Okay.
Yeah. Thank you.
Thank you. Thank you. That is fine. Thank you. Now, there's this important question of does health insurance improve health outcomes? That I would really want to hear broadly. What do we think? I'm going to ask Dr. Kelly, but I will also ask somebody else to really tell us. Maybe I'll ask Dr. Kohora as well to mention, because I know you have done some studies. I've looked at even what WHO has published about this, but I thought I needed to ask it. So maybe I'll ask Dr. Kelly, and then after that, please give the mic to Dr. Kihora as well, so that he'll answer. Thank you.
Thank you. Thank you so much, Dr. Nyawira. There's a close correlation between health financing and health outcomes. First, because in a population like ours, where, as per the statistics of SHA, 16% are extremely poor, and 12% of the population are basically neither here nor there in terms of expenditure in healthcare. And 7% of this population risk catastrophic financial circumstances if they were to engage in financing out-of-pocket healthcare. It therefore is important for a country like ours to move towards universal health coverage. And in the universal health coverage, one of the key pillars, therefore, is financing for that to work. And financing takes care of the continuum in the whole economic spectrum, meaning in a population, there will be those who are able to pay and can actually even access private medical insurance. There are those in the same population who are not able to access even the most basic of medical insurance, and therefore they depend on out-of-pocket. Not everyone is engaged in gainful employment. Some and most of the our population, over 16%, are not actually engaged in economic activities that are gainful in terms of being able to take care of the insurance as a whole. And therefore, there ought to be a universal way of addressing health financing. And that is what SHA has come to do. And to be able to make sure that every individual, being a right in the Constitution to quality healthcare, is able to access it. And as you have heard before, there are those among us who know that they are sick, they know that they need care, but are not able to access it because of a barrier that is very key in accessing that care. And therefore, it means that the health outcomes of such members in the population cannot be guaranteed without a medical insurance that covers through a universal health coverage format. And therefore, it is my proposal and it is my belief that health insurance, particularly a universal one that is crafted to take care of all spectrum in the economic pyramid, is substantially useful for assuring health outcomes. Dr. Kuhora, you can add to it.
Tell us if there are differences in cancer care outcomes between the insured and the non-insured.
Thank you. Does health insurance improve health outcomes? I would say yes. And just to elaborate on the figures, when it comes to the population and the classification by income bands, it is 16%, which is extremely poor, up to 28%, that is an additional 12% that is food poor, and then up to 35%, which is dollar poor. So that population is still considered to be poor. Now, of the population, 65%, which is not poor, the studies in 2018 showed that 7.1% went into poverty just because of one disease. So that is the impact of catastrophic health expenditure. Now, the question is, does it improve health outcomes? Yes, it does. And how it does it is, one is that it distributes the risk. Because when you have a larger population being insured, and that is what we are targeting, then you distribute the risk as opposed to one person spending for their healthcare. You have many people contributing into a pool, and that pool is used to finance a broader population. I think you've heard of the concept under social insurer, where the ones who are well or who are better off health-wise, they pay for the ones who are sicker, because there's a population which is going to be utilizing more compared to what they are contributing. Just to put it into perspective, on average, we've been spending more than 700,000 shillings per patient per year on dialysis. But this patient is contributing, or this person is contributing 6,000 shillings. So there is a population that is contributing but not utilizing to be able to support this person who needs quite a lot to manage their condition but cannot afford that full amount. If it was that one person, very few people will be able to afford the 700,000 shillings per year. So yes, it is meant to improve health outcomes. There are challenges in our environment. One of the key challenges that we've had is that we don't have a data trail or that patient journey all the way to the point of the outcome. Exactly when you are financing a cancer, for example, what outcome are you targeting? Are you targeting that you are going to eradicate the disease? Are you targeting that you are going to control the disease? Are you targeting that you are going to prolong the life, and by how many years? We have not gotten there yet, so that we can say that we are financing this particular health outcome, but it's one of the key deliverables that we are looking at. How do we achieve this? We had designed what we are calling a P4P, a payment for performance, where we use a financial inducement to get that outcome from a particular facility. If an example would be maybe maternal mortality. We have spent almost 16 billion shillings over the last 4 years to support hospital deliveries. Has that led to a reduction in infant mortality generally in the country? Has that led to a reduction in infant mortality because of financing skilled deliveries? Now, that is what we monitor, and for the facilities where they've been able to achieve that outcome, we seek to recognize them and provide a financial incentive. For the ones where the outcomes are actually low, I think Dr. Kariuki mentioned that there's always a carrot and a stick way of dealing with that.
Thank you very much, Daktari. You have mentioned some of the indicators, and that we may need in the future to be able to track so that you are able to tell exactly what has happened. Maybe the question is then, who should track? Because we have a human resource for health. Who should track? And how should we train them? What should they be able to do? I'm aware that, Dr. Kelly, we are training people in Diploma in Health Insurance Management. They are in their first year, and we want them to do something. There are some areas that have been mentioned, like from Dr. Kohora, and earlier we heard from even Dr. Kariuki, the team that was here earlier. There are still issues like fraud, default, there's means testing, there is sensitization, there is keeping records, there is having a registry, there is monitoring, compliance. What do you foresee the people in Diploma in Health Management will be able to do?
Thank you, Dr. Nyawira. The initiative to start the medical insurance course, a management course in Kenya Medical Training College, emanates from a felt need. And the felt need is both in private sector and in public sector. For universal health coverage to work, health financing must work. And for health financing to work, SHA has to have competent, qualified, and available adequate human resources for health to support the interventions at various levels, right from registration of members into SHA. We as Kenya Medical Training College are cognizant of the need for every Kenyan to enroll into SHA. And as a matter of fact, Kenya Medical Training College has been given a responsibility to facilitate and work with SHA in registration in 2 counties, that is the county of Kisumu and the county of Homa Bay. Some of the challenges we have faced as we do this is, number one, inadequacy of human resources who can support the Ngao, Kmtc, the county in registration. The kind of professionals we are training right now in medical insurance management are supposed to make this process more effective and efficient to ensure that anyone who is asking to register for SHA is capable of registering. Another issue that came out as we were doing registration is lack of information. What is the benefit of registration? What is the scope of cover? Who is eligible to be registered? And we have been working with community health promoters, and we have been working with employees of SHA, we've been working with the county employees. But these questions could easily be well answered if we had a professional at that level who could be able to, at the point of registration, provide sufficient, adequate information. And we have together generated some frequently asked questions. If we had professionals in this area, the way Kmtc has made interventions to have them, then this will be very important in sensitization, registration, and being able to communicate on eligibility criteria of registration to SHA, given that all of us are supposed to support and ensure that everybody is registered into SHA. There's the issue of subscription, monthly subscription into the scheme. I know we have individual contributors to the scheme. We also have institutional contributors to the scheme. How do we ensure that there's compliance? How do we make sure that the scheme has adequate resources to cover the illnesses and the population? It means that everybody has to contribute to the scheme. We are envisioning that if this training takes place, we will have adequate human resources for health who can follow up on subscriptions and make sure that there's adequate registration on a monthly basis. This will not only improve the financial situation for SHA, but will also ensure that everybody is adequately covered for the illnesses that we seek to have interventions for. Therefore, if we have defaulters, then this profession then are able to update and make sure that we have reminders that efficiency is introduced in the process. The other issue that has been a challenge, and it has been pointed out here, is the fraud that comes with claims management. We know that SHA is doing everything to prevent fraud, but fraud has far-reaching consequences in the scheme because it means that we are denying eligible beneficiaries from actually accessing care because majority of that resource goes into wastage because of fraud. We are envisioning that when we are able to train and graduate professionals who are able to identify disease patterns, disease criteria, and be able to examine claims, then we will significantly reduce the incidences of fraud. If we are able to do so, then we can make sure that the cover benefits as many people as possible. Then there is the issue of ensuring that we have adequately managed registry, adequately managed records in relation to diseases that affect majority of the population in Kenya. We are confident that the kind of graduates that we will have the capacity to support in registry records, keeping records of staging, that even as we look for registrars to support in various facilities, we are able to make sure that those records are adequately kept, they're accurate, and are able to inform us. Because if we do not have data, then decisions we make are made out of intuition rather than out of the reality of the situation. And therefore, this group are then able to make us more efficient in making sure that SHA does its work. not only SHA, but even private medical insurance. They will have a group of professionals who know what they're doing, take lesser and lesser time to train with emerging technologies, because they will already have been taught that as a basic course at Kenya Medical Training College. So we are confident that having worked and engaged various stakeholders, both at private medical insurance and at SHA, and other stakeholders who are very critical in ensuring that this process is successful. And the curriculum having been gone through a lot of stakeholder engagement, we believe that this intervention is going to support us to have a more efficient, a more robust, a more effective SHA. Thank you.
Thank you very much, Dr. Kelly. You've mentioned the gap that this course is trying to fill, because we have human resource for health, but none of them is actually addressing those key issues that he has mentioned. And he has also mentioned on the demand side, how they'll help to create demand. They'll look at the demand side. He's mentioned some things on the supply side that need to be addressed. And he has also mentioned the issue of sustainability, financial sustainability, by looking at subscriptions, looking at how we're going. So we need people to look into that. I will be looking out to hear your thoughts. Right now, what is happening in the health facility, whether you have somebody dealing with that and how that can happen. So I will want to prepare Dr. our Deputy CEO at JOTRH. I'll ask you to maybe tell us right now, demand side, in response to what Dr. Kelly has mentioned. How can these people come in? What areas do you see as of now at the hospital and any other hospital? I know we have mission hospitals here. We have private hospitals like MP Shah here, but I'll give you, Daktari, to talk about it. But just before, as you prepare, I want to talk to Dr. Kande. At KNQA, I know you aim to promote employability of people who are trained, those who have the qualifications. I know you look at whether the work that they get is decent work, because we have an SDG on decent work. I know you look at the opportunities for entrepreneurship, the opportunities for them to continue learning, even after they've finished, what we call lifelong learning. Now, how do you see, we have a diploma in health insurance occasioned by the emerging needs. What do you see ahead that we should think about in terms of employability, the work environment, what makes decent work? How can they engage in entrepreneurship or support us? They support the hospitals, because we are saying financial sustainability is really important. And how do we ensure they have lifelong learning? Thank you. Mm-hmm.
Thank you very much, our moderator, Daktari, for that question, and good morning once again. Let me introduce myself. My name is Alice Kande, CEO of Kenya National Qualifications Authority, and I would like to put a disclaimer here that I am not a medic. I am not a medical practitioner. Mine is just in the line of academia, so you feel I've fallen short of the medic language. Maybe that's a reason. But I am glad to be here this morning, because nevertheless, from the agency where I am coming from, the Kenya National Qualifications Authority, we see ourselves as an active voice across board, because basically we appreciate the skills and qualifications are very, very critical. It's a very critical component for any progressive country, for any progressive society. And it is quite exciting to see that we are in this kind of a convening to discuss something that is very paramount, something that is so current, something that is so present for us, about universal health care, about what is so pressing in terms of relevance of our health system. And now in our context, looking at, are we ready in terms of human resources? And I want to ride on or echo what my colleague, Dr. Kelly, has rightly put across, that we need able, well-prepared human resources. And that is where Kenya National Qualifications come in. Allow me to say that we are an agency under the Ministry of Education. We're under the State Department for TVET, but our role cuts across basically to ensure that there is harmony, there is standard in the way we undertake education and training in this country, but most importantly, looking at the ultimate result of the entire continuum of education and training. That is a certificate that we get, the qualifications at the end of the education and training process. So we want to check acceptability qualification. Does it speak to the current need in the labor market? We are looking at global competitiveness. Does it just speak to our very small space where we are? We are speaking to the acceptability by the labor market as well. And I am happy then to jump in at this point to say that when we talk about having credible qualifications registered in the Kenya National Qualifications Framework, then we are talking about a qualification that has passed through the kind of a discussion that we are having here, that has the voice of the industry. It really pleases my heart, because whenever we're looking at the criteria for registration of a program in the National Qualifications Database, the very first thing we want to check, the issue of currency. And currency can only be informed by the voice of the industry players, like you yourselves who are here. And when I looked at this diploma in health insurance management, then the first thing I asked Dr. Kelly is whether it is already a running program, and he said yes. And I believe this is one of the programs that we shall be registering in the framework. Happy to say that we are already speaking to what is it that it will address? What is it that is the need that has been seen out there? Because whenever we talk about employability, the gap, of course, that we are seeing in the labor market, and the issues of the skills mismatch, that of course we are talking about having our graduates, they get out with very good certificates and they're not finding places in the labor market. It is caused by the gap between, of course, the demand and the supply side, the qualifications awarding institutions, like we call them, and that is where we would categorize the Kmtc, and the labor market yourselves who are in the industry. And so to say then in brief, where we would see this in terms of the place of this kind of a program and other programs that we have in addressing employability, for me, I would say that this kind of a conversation that we're having would actually fill in that gap. Because it means outrightly from the onset, we are saying the way we have packaged this qualification, it means right from, if you are packaged in terms of units, we know every single unit addresses a specific need. And if, for instance, a student, be they in their first year or their second year, were they to get to the industry, any of the hospitals here or any of the medical facility, then they would find something to do. And that is basically what the National Qualifications Framework speaks to. That we do not even necessarily have to wait for one to exit after their 3 years of learning, after their 4 years of learning, after their 5 years of learning. It means that what we are equipping and skilling our students with, they can actually get to the industry and they will work. What they have what they have acquired is actually something that is relevant that would make use of it. And so for me, I think I would just want to congratulate KMTC and all of yourselves for really putting this together, and of course finding a place in which this can be applicable in helping our country to achieve the very much envisaged and intended universal health care, a working universal health care system, because it means it has to be driven by people who are adequately skilled, by people who really understand what is expected of them. And so for us to ensure then that there is lifelong learning, because that is also a key component of the National Qualifications Framework, we are looking at how do we articulate the components of the programs that we have. And that takes me back to the earlier point that I was saying. I would look at the levels, what I have in year one, what I have in year two. And even after I have finalized this diploma, what pathway have we provided for these students? Do they have an opportunity to climb up as well? That is the articulation that we'd like to see. So that when we are placing it in the framework, we can see when one is moving from level 6, that is a diploma, and getting to level 7, we can actually see the additional knowledge that we're saying that they will be equipped with. And so that we avoid redundancy of knowledge, and also failure to acknowledge what one has learned. So we are happy from where we are, again, to work very closely with KMTC, to also be enjoined in this conversation with your key stakeholders like SHA and all of you who are here, because collectively we will ensure that our qualifications really meet the requirements of the times that we are at. We are not just there to say that we have all these graduates. No, we want to say that we have these have gone through our systems, and we can confidently say that they will make use of what they have learned. We are also looking at how we work collaboratively to ensure that we are promoting portability of these qualifications. Like I said, may not consume all these graduates within our space. We're looking at global competitiveness of our qualifications. When they get out there beyond our boundaries, where are they placed? Are they taken back to levels slower than where we have placed them? Allow me to say at this point, as the Kenya National Qualifications Authority, we are really putting a voice beyond our boundaries so that our qualifications are considered for what they are out there, regionally and continentally. We're working under an umbrella body within the continent called Africa Continental Qualifications Framework. We're working very closely with our sister institutions within the continent, South Africa and others. Generally, 40 out of the 55 countries in Africa, all of them have a form of a National Qualifications Authority like what we have here. And so what we're doing is to ensure this comparability of our qualifications. And so how would these graduates with health insurance come in and help with health in the county to really make it work? So let me first give
Thanks very much for this chance to make my comments on the issue that you've just talked about. I'm Dr. Dida Nongonga. I'm the Director of Clinical Services at JOTRH and also the Deputy CEO for JOTRH. Before commenting on what you have asked me to comment on, I had a comment on the first issue that you are talking about. Does health insurance improve the outcome of health in our population? I wanted to look at it from the provider perspective, especially when you talk about the government institutions. We have been having challenges with patients able to pay for the cost of the services. And we find a big portion of our patients have to be waived their bills because they cannot afford. So when we talk about the health insurance, then we are reducing the numbers of patients coming for out-of-pocket payment. And with reduction of waiver, we are going to increase the revenue that the facility will generate. And with increasing the revenue, these facilities will be able to develop and put in place more equipments to provide better services to the population. So yes, I agree with health insurance. We are going to first improve the care in terms of the facilities that we have, and we are also going to reduce the number of those people who cannot afford. I just wanted to add, like the experience we had with the teachers, before the teachers had the medical cover, and the time they had the cover, and I remember the number of teachers who presented with many chronic surgical conditions that they've been living with. And with that, we could appreciate the health conditions of the teachers improved. And I think that will go across once we have this universal cover. Now, on the second issue that you've asked me to comment about, this training on health insurance management, is it relevant? Yes. Is there a market for it? Yes. But I wanted to look at it in two ways. As Dr. Kelly has talked about, these officers being able to support in recruitment, registration, follow-up, and this kind of activities. This is very important. But we can also use them or train them or skill them to support the insurance industry in reducing the fraud that we have talked about. And my thoughts were, if you could look at, let's say you take people who have trained in nursing, clinical, and all those clinical related trainings, then you now empower them with the skills to be able to support the industry. They'll be able to evaluate these patients who are admitted in these facilities and advise the insurance. Is it the relevant condition? Is it something that requires this kind of intervention? And is it something like you find a patient can be admitted for 10 days for a condition that may require only 3 days? But if you don't have somebody with that clinical background, then you'll find the insurance will waste a lot of resources. And again, the hospitals have challenges in terms of processing of claims and these other things. Because here, you have clerks who are trained to fill forms and that kind of thing. But if you have this group also skilled in a way that they can be able to look at the whole process of insurance and supporting in the processing of claims, the pre-authorizations and all this, I think they'll be a more useful group both to the insurance industry, to the health facilities, and also to the country as a whole to support the universal health coverage. Thanks. Those are my comments. Thanks.
Thank you very much.
Thank you very much. As I introduced myself earlier, my name is Dr. Daniel Wainaina. I'm the County Director of Medical Services in the County Government of Nakuru. And it's a pleasure to give my contribution. I think I'm the sole county voice. I didn't hear anyone else introduce themselves as from the counties. One, I would like to look at this in maybe from 3 angles. From the college side, I really want to commend Kmtc for being in the forefront in terms of fashioning courses that are relevant to the current situation. I think a lot of our learning institutions of higher learning should learn from Kmtc in terms of that, because we have had very many courses that may no longer apply in the modern day that are still being offered in many of our institutions. As an employer, the county governments being the bulk of the employer in health at the moment, I would look at it as in terms of what would be the career path of these new trainees in terms of where they enter, what is their role, do they have a scheme of service and all that. I would look at this as also as who has been carrying out this role at the moment. SHA may be new, but NHIF was there. We also have private insurances. Whose role are these people coming to take in or to enhance? And I would think of maybe we should also look at the possibility of having or in-service training for cadres that are already in health. For instance, the health administrators, nursing managers, and others who've been carrying this role, maybe at a level of a higher national diploma or an in-service course, as much as we wait for this first lot and the subsequent lots. And I think the other thing I would also want to look at is these courses may sound, maybe this may be personal, like a unit in maybe in health, in HSM, or in other courses. And as I look at it that way, I would like to recommend that it also, part of this be a unit in all the undergraduate trainings for all medical trainees, so that as they qualify, they have some elementary or whichever basic knowledge on health insurance as we move forward to implement this. Lastly, I think I want to say that we must also be very much aware that as we begin, there's a lot of hype in terms of registration. It's a new thing. There's a lot of work, but moving forward, probably there may be mechanisms that may be put in place that may negate the role of continuous registration. Probably we are going to have a single number like the Huduma and all that, where everyone at whatever point of interaction with government systems will already be registered. Then we'll have better enhanced systems in terms of monitoring. We'll have better use of AI and such. So we must also look at the numbers so that we do not overproduce. And then I think probably I'm speaking like a parent, then our children do not have opportunities. But I see a lot of hope and potential for the first few lots. But thereafter, we must think about what will happen to the cohorts that will follow. Thank you.
Thank you very much. And I know Principal is here. He's taking note of the comments, plus the KMTC team handling this course. You're taking comments. The suggestions, I know that Dr. Angonga has suggested that if you have people with a medical background doing this, they could fit in to understand it better. And so I think the suggestion is like of a higher diploma. And the same thing Dr. Wainaina has mentioned. Then he has said that we have to think about the career pathway carefully. He's also mentioned that we need to make these a common unit across many of our cadres. He's saying we also have to be cognizant of the changes that might occur, and then to think about whether we need a cadre separately dealing with this, whether there will be employability in the years to come, and then how to marry that. So quite a number of thoughts there about how to organize the program. We're taking note, and we'll comment, we'll look into it, and maybe at the end, if there's a comment, I'll ask you to give. But for now, I would want us to continue the conversation. There's a lot of comment about even the private sector, there is insurance. And I'd really want to have a comment from the private sector insurance. I know we have a number of them. Any of them can put up their hand, but can I first of all just ask at random CIC insurance comment about how these people with diploma in health insurance management would fit in? CIC, you have, yes, please.
Okay, just to comment on the issue of the people with a diploma in, maybe already there's a background of a diploma in a health-related course. I would say the industry, the private insurance industry currently, that is the model that is in operation. You find there are a number of nurses, clinical officers who are currently doing the job at the insurance industry, especially the private sector. I want to echo what Dr. said here in terms of pre-authorization, claim management, service provider partnership, engagement. Those are the people currently handling that. And I want to agree that if that can be incorporated, if the course can be incorporated as an hand-on on what is already existing, then it gives this team a layer of knowledge, because personally, my training is nursing. I am an alumni of Kmtc, though went on to diversify on other areas. But I can say that when we get into the insurance sector, the first time that we got in there, it was quite a very gray, a very green place, because you're used to the hospital, you're taught nursing, you're taught clinical medicine, but then you're here dealing with patients from a desk perspective, from an office perspective. So I would say that model would really work well, because it could enrich the information that these cadres already have and be able to place them in a place. They can function both in hospitals, in the insurance sector, because number one, they are able to deal, to handle other colleagues. They are able to handle doctors. They are able to interpret and to appreciate what is it that is happening to these patients who are admitted. And there, on the other side also, there's that capability of being able to understand how insurance and how that is interconnected. So I would really, from where I sit, and here I think also on behalf of the private insurance, recommend that this becomes like a higher diploma, and also what Dr. from Nakuru recommended, that it's incorporated as a unity for other courses, because sometimes you deal with colleagues in the hospital, and they understand medicine, they don't understand the other side of insurance. So if that can happen, it is going to be a good thing. But I want to commend the KMTC, because that is you are responding to the needs that are emerging in the market, which I think is very much commendable. Thank you.
Thank you very much. I didn't get your name, please.
Mary Mugambi.
Mary Mugabi, thank you. Thank you very much. Mary Mugabi, I believe she has spoken for the private sector. There will still be opportunities for if you want to add on. I thank you for those comments. Maybe I can ask Mr. Samuel from the Association of Health Administrators, from that health system perspective, administration perspective, what are your thoughts about this program? He's at the front there.
Good morning, and thank you for probing me to say something about this. Currently in hospitals, we have some clerks that are hired by the county governments to do registration, to do claims, to do all those things related to health insurance. And I think that they do not have training per se. They learn on the job. They liaise with the local insurance companies, particularly SHA and NHIF before. And those are the staff that we have had. And they're not very many, they are few. So I think the introduction of this course at KMTC is a very positive move. It's a very positive move, because then it provides a cadre that's going to relevantly deal with a need that we have on the pillar of financing health. Personally, I was thinking that making the other cadres like clinic officers or nurses to take this course, this is my personal view, would much as it will diversify their knowledge, it will also deny specialization. If I have a nurse who I will have to need to leave the nursing service to come and deal with insurance issues, personally, I would think that would be over diversifying. So I prefer that the insurance issues are dealt with by a particular cadre. Like we have the health records, people dealing with health records. When it comes to financing, we have people dealing with that. Then we leave the nurses and clinic officers to deal with their role. That is my perspective. Thank you.
I thank you very much. Thank you. This is a very good discussion. Let us see the tensions between all these decisions. Just like we were told with insurance, they had to prioritize after considering, let's consider how best do we use our human resource, but also how effective can they be. Like at the end, you have mentioned like within health records, maybe they can also throw a spanner. Should this be a program that is a higher diploma in health records, a background of health records? We have also had a background of other medical programs. Or should it be somebody from the start with insurance? Let's have this conversation. I want to just go to one final area because of time, or two final areas together, is the area of research and the area of partnership for training and also for improving health services. So we had like there's still a lot that is not yet known around health financing in our population. Impact of different things. We collect lots of data, but I'm sure we still haven't answered many of the research questions. Some of them that were discussed in the previous panels. We talked about various indicators, and even in these areas of research around fraud and subscriptions, who should pay how much. I think Dr. told us at the moment we are all paying 2.75%, but some countries have done, a progressive kind of way. Now, there were issues of regulation. I'm sure there is research around regulation about compliance. So there are several areas. I would want to ask Dr. Kelly, what do you think about research? How can we fit into the research agenda? Are we preparing our students for research? Then also around partnership, because we are many here, we are stakeholders. How can the stakeholders here play a role in the supporting the objectives of the training? So I'll ask that from Dr. Kelly. I'll also ask that from Dr. Kande. How do you think we can factor in the qualifications and recognize research, partnership, things that, because research informs practice, it also informs training. Like in KA and QA, I'd like to know what kind of research do you do around qualifications and how can we fit in? Thank you.
Thank you, Dr. Nyawera. I will start by addressing the issues of research. They say what is known is a drop, what is not known is an ocean. In terms of health financing, I know there is a body of research that currently is available. But as SHA representative for the CEO is saying, we do not have conclusive information in many, many areas. Like, to what extent is fraud affecting coverage? That still remains a very big question, because how do we then make interventions if we do not have facts? So research is supposed to generate information, generate knowledge, generate a way of looking at patterns and looking at whether those patterns can help us make decisions. As we make decisions, yes, we depend on experience, but it is more important if data was available and that data has been generated scientifically. At Kenya Medical Training College, one of our mandates is research. And therefore, we start by starting from the most basic bit of it, allowing our students to engage in research, supervise them, making sure that they have a way of learning how to be inquisitive to carry out research that is credible. We also empower our faculty to take up research, and we have staff who want to carry out research. We also promote joint researches that are being done among staff or collaborative researches that generate data both from student perspective and staff perspective. But we also know that our partners have knowledge that may not be organized in such a way that then becomes researchable and being able to give us information that we can use for decision making. Such format that we have like today is an opportunity to encourage more partnership. As we talk here and as we get perspectives from everyone, I'm very glad that most of you are here today. There are things that we wouldn't know from when we would be talking to ourselves. But now that we have you in this kind of discussion, it gives us in-depth understanding that we would not even be able to start imagining from our own perspective. And therefore, stakeholders become very key in engagement with an organization like Kmtc. We have a perspective from our colleague CEO from National Qualifications Authority. From education's perspective, how then do you create a cadre? How do you make sure they progress? How do you make sure that the cadre is available in the market? How do you make sure that the market needs that cadre? So that kind of stakeholder engagement then gives us ability to have conclusive ideas of how to manage a new intervention like what we propose to have and what we already have about medical insurance management. So therefore, what is the place of research in Kmtc? It is supposed to help us generate knowledge, new knowledge that then can be used for decision making. It is supposed to inform policy. And this is where we are able to then generate knowledge that when patterns are identified, then enables us to have policies that direct effectiveness and efficiency in service delivery. And then it's supposed to help us inform practice. There are views about, for example, how do we include this cadre? Is it do we create an entirely new cadre? Do we cross-scale existing cadres? So in real sense, this is a very important discourse and could easily be generated into a research question as to whether we would be better off having a new cadre or we would be better off having already existing cadres doing this, with both views supporting, other views not supporting. So we are open to research. We, as an organization, have that as a mandate. And stakeholder engagement becomes very key to us in terms of, number one, giving us opportunities for feedback. Number two, most of the stakeholders here then will become very key when we are attaching our students to the industry. The stakeholders here would be the bridge that connects our students from the academic perspective to the work environment. We are proud, for example, that one of our alumni, Mary Mugambi, who has just given us a contribution concerning this course, is already working in insurance. If we have students who need to gain knowledge through attachment in insurance, these stakeholders then become very key in that we have opportunities, therefore, to allow them to participate in mentoring our students. They are very key in terms of then providing guidance and also future opportunities for our students once they are done with the learning at Kenya Medical Training College. So the potential of partnerships, collaborations cannot be underestimated in such a scenario as we are here. You can see for sure that it is through this partnership and collaboration and stakeholder engagement that we are now able to see the perspectives that we ourselves would be blind to, because we would not know some of everything about what we need to do. Thank you.
Thank you very much. Dr. Kande.
Thank Thank you very much, Dr. And I also appreciate the very great thinking that is going through this room. And on this issue of research, I want to agree with Dr. Kelly that research is really integral. And for our case, we are looking at the criticality of research in informing the quality of qualifications that we have in this country. And one of our key functions as the Kenya National Qualifications Authority is to undertake research that would inform qualifications that we have and that we register in the National Qualifications Database. And that means from what we gather, we are able to interact with very critical players. And most of the critical players here actively involved would be the labor market. Because we want to see that the qualification that is being registered, is it still relevant? Is it still current? So we want to hear the voice so that we can be able to see that there is a gap that it is actually addressing. And therefore we are able to really see that this feedback that we're getting, this output that we're getting from any form of research that we undertake, it will actually inform the decisions that we make in terms of really registering and saying that, yes, this is an important program that we are glad to make visible and say that it is a national qualification in the country. So I would like to say that it is really a foundation that informs the basis of our functionality, and part of the criteria that we look at when we are registering the qualification is to check, how has a qualification awarding institution made advantage of the information that is out there in the labor market? What does the labor market information system probably say about this pressing need? Do we still have a glaring gap between what we are providing and what we are proposing to package and to offer as a program versus what the labor market is expecting? In other words, we're saying that with research, we are able to really confidently talk about skills anticipation, and so that from that skills anticipation report, you are able to really talk about the relevance of the programs that we are having as a country in various spaces. And of course, speaking to how then does this program lead to skilling of the people that we have aimed at. Is it reskilling that we're looking at? For instance, if you look at this specific program, are we looking at it probably as part of an additional knowledge that one who is already practicing and has already learned something that they need to learn as part of what they are already doing. So it really informs whether are we looking at comprehensive kind of skilling, or it's just reskilling the people who are there, or it is part of cross-skilling. And it was interesting to hear about the conversation from the insurance industry and the standpoint of other industry players on, do we make it a standalone program, or do we make it an acceptable way of cross-skilling our practitioners? So the output that we get from research really would inform these kinds of questions. And so from our end, really research is very critical, and of course the fact that we're also very keen in ensuring that we have a database of the qualifications that we ultimately get from all the programs that we have across board. We know data is a current engine. It's a lot that we are doing and dealing with data, so that is a very critical component for us. That's what I would say for now. Thanks.
I thank you, Dr. Kade. Yes, at that point, you said it's a very data-rich area, health insurance, and also there's a lot of research that is required. I have many, many questions I would like to ask. I would have questions for Kemri, questions for who and who, but unfortunately I've run out of time. So what I'm going to ask when we go for tea, I know you had questions, please forward them, then we can factor in some question time in the next plenary, but now we have to break for tea. allow me to thank my panelists very much. Can I give you 1 second, just a closing word for that one word each?
Thank you. We, as Kenya Medical Training College, as we embark on the journey of filling this gap, require the input of everyone. We do not want to take for granted that we have a lot of professionals in this area. We have people with knowledge and experience that, if shared, then would enable us to have a better product that is able to fit the needs of the market. And therefore, we are open to discussion, we are open to views, we are open to ensuring that we give our best as we ensure that we close the gap that is existing in the industry. Thank you.
Thank you, Dr. Kade, and then Dr. Koja.
Thank you so much. Mine would be that we all have a critical role in this space, and especially when we look at equipping our human resources, when we look at the qualifications, let's keep voicing from where we are. Let's not just sit in our roles and say that we already have the programs that are already addressing, or we just seated at industry players and employers waiting for the graduates. Let us actively participate in this space so that we shall all comfortably say that we are glad and happy about the nature of qualifications and the graduates that we are churning from our institutions. We all have a critical role to play in closing the unemployability gap that we have in this country. Thank you.
Great. And having been silent most of the time, by design and also bound by protocol, what I can commit to is that WHO is open to continue our consultations behind and come to this forum to continue to inform it. And so for the opportunity that was missed, we will align with direct, WHO is able to participate in this discourse in an open and fair manner, following protocol. So don't cancel us out. I was actually itching to speak from here, but for today's discourse, I will not. Yes. Thank you.
Thank you very much. I want to give it to the MC from here.
Thank you very much, Dr. Nyawera. Thank you so much, Dr. Uluoch. Thank you so much, Dr. Kande. And thank you so much, Dr. Kojo. So we have come to the end of the first two panels, and we wish to take a tea break now. But of course, we have to give them a signature clap even as we wind up from here. We will give them the three that we have been doing. So let's put our hands together. Let's give them one. Let's give them a better one. Let's give them one, and another one, and another one. Thank you so much. So it's now 11:26. We take a tea break for, did we say 20 minutes, timekeeper? 20 minutes. So that means we should be back by 11:46. So kindly let's go out, have our coffee, have our tea, then we come back for the third panel at 11:46. I'm seeing someone saying let us make it 11:50, right? So we'll be back by 11:50. Enjoy.
Will be Dr. Daniel Wainaina, the Director Medical Services, Nakuru County. Karibu. And have the first seat on the right. We have Dr. Dedan Ongonga from JOTTRH, or is it JOTRH? JOOTRH. Welcome. You can have the first seat. Dr. Oluga, we saw you somewhere. He's on phone, okay. So he will join the team. Then Dr. Kohora, we have you on the hot seat again. You're representing the new baby on the... So Dr. Luga shall join in. And I think Dr. Luge, I know we know that you're familiar with health insurance in this country. Yes. Welcome to let's introduce our fourth. This is Dr. Uma Oluga, who is now the Director, Health Sector Coordination at the Ministry of Health. Karibu sana. Madam Fodosa, the gentlemen are yours.
Good afternoon, everyone. Thank you, all the panel members. Before I start, I would ask the panel members, do you have any conflict or any reason why you can't contribute to the discussion? I'm not going to start before you declare. And that's just on a light note so that we get to have people contributing freely. Now, we are going to build a lot from the panel that has just left. I'm sure all of you were in the room. They had a very fruitful discussion when it came to health insurance, the diploma program that has been now rolled out by Kmtc. There's been a good discussion in line with partnership. There's also been a very good discussion in line with research. So we are going to move now to the third session. Our third session is going to be about healthcare. And we are going to concentrate on 3 key pillars, and that is going to be quality. We are going to have a discussion around accessibility and also affordability, and then try to see how do we link all that in the provision of health insurance for all. Now, let's start the discussion around quality. And I'm going to start with my panelist at the far end, and that is going to be Dr. Oluga. Healthcare. It's very important to integrate quality in healthcare because it increases the livelihood and the desired outcomes. So, in line with that, what do you think are mostly the factors that would affect quality of healthcare in Kenya?
Thank you so much, and good afternoon to everyone. Yes, my name is Ouma Oluga, and I'm the Acting Director for Health Sector Coordination and Research. And let me just take 30 seconds to unpack that. So basically, we are responsible for facilitating coordination between Ministry of Health and all other agencies, grouped in the following 4 ways. One, of course, is the county government, where we are looking at intergovernmental relations, and you know, Ministry of Health is in charge of the policy, the standards, capacity assistance, and referral networks, and then the county governments are the core of service delivery. So any interface there is our responsibility. Second is international health relations, and that is where the multilateral agencies, the World Health Organization, the World Bank, UNICEF, UNFPA, and all agencies really at the international level that are either government bodies, multilateral, bilateral engagements with the organizations and countries such as the UK, which I think includes the bilateral labor agreements that Kmtc is involved in, the MOUs with Switzerland, that is also us. Thirdly is health sector partnerships, and that is where the NGOs, the CBOs, and all the actors within the health space, and these actors are either development actors or implementing actors. We deal also with them. And lastly, which is quite key, is internally within the ministries to really coordinate the agencies. And you know, the Ministry of Health have nearly 30 parastatals, which are either regulatory or implementing one or the other aspect of health policy within the ministry, and also certainly now with 2 state departments and several directorates, that internal coordination to make sure that the ministry is moving as one. So having mentioned my role is to now get to the question around quality. And first to mention exactly the Ministry of Health a framework for quality. So there is what we call the Kenya Quality Model for Health. And the Kenya Quality Model for Health was passed in 2016, and it has been disseminated to county governments. I think 16 county governments are in some process of implementing it. And the Kenya Quality Model was looking at the star, the star rating model of looking at quality. And it is basically, it's a customized between what is known internationally as the Joint Commission for the JCI, the Joint Commission International for Accreditation, which has a quality model specifically for hospitals, and what our colleagues in South Africa have done, which is the COSASA, which is the Council for Health Professionals Association of South Africa, which was as a quality. So I think looking at those two, there was customization for Kenyan system, for the Kenyan context. And that is how we came up with the Kenya Quality Model for Health, which is the standing framework upon which we look at many of our hospitals. But 2 things have also happened, which is quite key for your knowledge. One is that the Kenya Bureau of Standards, for the first time, and engaging with the Ministry of Health, have an ISO standard, which is ISO 71001, looking at the quality of healthcare. And the second thing that has happened is that with the passing of the 4 laws that are going to steer the health sector moving forward, and I know you know these 4 laws: the Digital Health Act, the Primary Healthcare Act, the Facility Improvement Financing Act, and the mention of an accrediting body for quality. And for the first time, I think there is realization that the registration of a hospital and the licensing of a hospital is different from the day-to-day checking of whether the service is quality. And so as we speak, there is the drafting stage of what we call a quality of care bill. And that's where we are moving to in the Ministry of Health. And so from the Kenya Quality Model for Health, which is sort of a policy framework, we are now moving towards the bill. And I know my colleague, Dr. Kuhora, will expand on that because it is going to inform what exactly SHA will pay for. And so I think it is important that I set that stage as far as the direction that the Ministry of Health is looking at. Now, having said that, then I come specifically to your question about the things that affect quality. And of course, the things that affect quality are only three. One is the environment within a service is provided, and two is the capacity of the people that are providing that service, and three is the resource that you require for that service to be provided. And so looking at the healthcare context, in terms of determining quality and defining what quality is, and quality is not a static thing, it's a moving process. So that's why it is always important to have a quality process rather than a quality parameter. So of course, the quality parameter, you can set a quality parameter or a quality indicator, but what is most important is the process that gets you there. And then the second thing is how then do you measure that you are in that journey towards that quality parameter? And then what are the activities that you do, the quality improvement activities that you do? And I think with those many remarks, I'll stop there and wait for other questions. Thank you.
Thank you very much, Dr. Oluga. I knew you'll set the pace. At least you've taken us through quality very well and what you do also at the ministry. Now I would like to give Dr. Kuhora the opportunity just to expand on the quality bill and how will it integrate with SHA.
Okay, thank you. On the aspects around the quality bill and what is envisioned, I think the elaboration has been made very clear that it's actually been provided for in law, that there needs to be an accrediting body, and its main function would be the quality of healthcare in the country. Now, how does it integrate with the payer perspective? Now, as a payer, what we target is value-based financing in healthcare. It's not just about paying for a service that has been delivered, but what value are you getting for that service that is being delivered? So if you pay for deliveries, for example, how many of those mothers complicated out of something that is related to a quality standard? If you're paying, let me give you a perspective, just a real life example. We were looking at the cost drivers across different benefits sometime in 2019. And from the quality indicators that we looked at, one of the things that is usually standard in the insurance world is the average length of stay. That is basically the duration of admission when it comes to the stay of a patient in a hospital. So we isolated specific surgeries because surgeries were costing about 26% of the total utilization. Major surgeries were doing about 92% of that. Then within the major surgeries, which ones are the most common? And then analyze them across different facilities. Now, the average duration of admission for the same procedure in a private facility was about 3 days. It's about 4.5 days in a faith-based facility. It's about 9 days in a government facility. So if you are looking at it from a quality perspective, what could be the challenge? Is it that there is an incentive to actually discharge this patient immediately, whether they have gotten to a point where you are comfortable discharging them or not? Is it that the waiting period between the admission and when the procedure was actually done is highest in government facilities? Maybe that's why it's taking 9 days. Is there something that is being missed out in terms of complications? Or could it be on the flip side, this patient and a complicate, make sure amekuwa referred immediately to a government facility, so the government is handling the more complex cases. So that's basically the perspective around quality. It is the same data, but where do you invest? Because there are variations in terms of the quality that you're getting depending on where you're having. So our main role is to integrate quality and the payer perspective so that we get to the best value for every shilling that is being spent out. Thank you.
Thank you. Thank you, Dr. Kohara. Now, a lot has been explained. As you've heard from Dr. Oluga, he's mentioned that there is also partnership between the ministry and Kenya Bureau of Standards, where there's an ISO standard that is coming up, or is it in existence? Okay. There is an accrediting body that will be coming in to play the role of quality. And then there's also a draft bill. And Dr. Kuhora has also explained and tried to bring us back to how health is an investment and how quality plays a key role. Now, back to the factors that affect quality. We've talked about the environment around where the service is offered. He's also mentioned about the issues of capacity, and finally, the issue of resources. Now, in the spirit of devolution, I would like now to welcome Dr. Wainaina to tell us what is the role health professions play in, and their expertise play in improving overall health quality. Kmtc have talked about them rolling out the diploma in health insurance. I'm sure there'll be a unit in quality, if I'm not wrong. How do you see that playing a role when it comes to quality?
Thank you very much. As mentioned earlier, the bulk of health service delivery is now at the counties, and especially more than ever, now than ever before when we are embracing the primary healthcare. And as such, we must therefore invest in the counties as we look at achieving the quality that we intend to achieve through the enactment of the 4 laws, as mentioned by Dr. Oluga, that are meant to actualize Article 43 of the Constitution. Having said that, we all know that the national government has very specific roles, especially in the issues of regulation, standards and policy, training, and of course the national referral facilities. So where does the county fit in? Where does the county fit in terms of the staff, the HR and its capacity, and how do they contribute to healthcare? One, of course, we rely on the regulatory bodies that are domiciled in at the national level. And Dr. Kariuki was here in the first session and explained how that happens. And he stated 2 or 3 items. One, he said that all health professionals must adhere to the scope of practice that they are trained for, so that they only offer the services which they are licensed and they are capable of doing that. And of course, within codes of ethics. And if we deviate from that, then there must be a disciplinary measure. The county governments are the biggest employers, but we rely on the standards as set by the national bodies. So as the management in the county level, our role is to ensure that, one, we have staff that are qualified, we have staff in adequate numbers, and I know that is a big issue. And also we are able to have the other elements of quality to enable these staff work in environments that will guarantee quality. And that's very well within the county governments. And as for Nakuru specifically, we've embarked on a huge infrastructural transformation that is enabling us to give a good environment for our workers to work. In terms of capacity building for short courses, for on-job trainings, for mentorships, we are able to do that. And for those longer courses, we are able to partner with our training institutions, including the national government for sponsorship of long-term trainings, especially for specialists. And in terms of resources, we are really happy with the passage of the FIF Act Nakuru has been a trailblazer in the same, and now with the laws, we are able to retain even more by bringing on board the level 2 and 3s that previously were not able to generate anything. But through SHA, these facilities are going to claim, and with more resources, as one of the health financing being one of the pillars of healthcare, then we are going to work towards that quality. But having said that, we are really, really far as a country from achieving the Abuja declaration in terms of financing. I think we are doing around 5%, 5 to 6 as a country, yet we are embarking on a very ambitious journey of ensuring that we have universal health coverage or care. For the counties, we are trying our best. For instance, for Nakuru, we are investing about 36% of the entire county budget to health. But again, what does that mean? When you break it down, most of this goes to HR and leaves very little for these other elements of quality that are there. So we will rely, the message is we are going to rely on the national government in terms of setting the pace, and also in terms of health financing, and in terms of regulation, policies and standards. And most importantly, specific to your question, in terms of training personnel or people who are fit, or human resource for health that is fit for purpose. Thank you.
Thank you, Dr. Now, maybe we would want to hear also from the provider's side so that they can tell us how do you see training of the health professions and how does it impact on quality?
I think first I'll start by a disclaimer. I'm a surgeon by training, so I speak less. So I'll not compete with the other panelists in the number of words that I use. Now, I just wanted to look at the aspect of quality from the provider perspective, and I'll use JOTRH as a case in point. For us at JOTRH, we are guided by a very basic philosophy. And our philosophy is we improve on what we have, we expand on it, and then we add to it. And for us, when we talk about improving and training, quality in training, we look at the equipments that we have on the ground, and we look at the human resource that is available. So when we have certain equipments, but we don't have human resource to utilize them, we put our resources on training of this human resource so that we are able to fully utilize the equipments that we have to improve the quality. Then we look at the human resource that we have on the ground, like we get postings from the county. For example, we get a urologist posted. We now look at, is this urologist fully utilized, his skills on the ground? So we now focus our resources on availing for him the equipment that he requires to utilize that. And then we look at the space we have for our patients, and then we improve on that. So as we go along, we'll now identify the next areas based on the demand from the clients that we serve. So for example, currently we are focusing on cardiovascular diseases. We are now working on sending people to be trained on this, and at the same time working on the infrastructure to be able to deliver this to our people. For us at UTRH, apart from providing the services, we also identify some of the specialization that are critical in our environment, and we work together with the universities to come up with the postgraduate trainings to be able to meet the demands of our population. So, like at the moment, we are working together with Maseno University, who has started now the postgraduate trainings in internal medicine, surgery, and that kind of thing. And also, we work together in terms of training with what we call the East, Central, and South African colleges. And we're already having trainings ongoing in surgery, obstetric, gynecology, internal medicine, and that kind of thing. So we work together with the training institutions to identify the gaps so that we focus on those gaps to train the human resource to improve quality. And then we now look at the human resource we have available. We work on the equipments for them to be able to deliver. And then we look at the new horizons to invest in. Those will be my comments.
Thank you very much, Dr. I like the motto that we improve on what we have and then expand and add on what we also have. I think that is something that now, this discussion cannot end without us discussing about technology. And when it comes to technology, I want us to have a discussion around how do we integrate technology without impacting, and what is the impact on quality. And I will allow all our panelists like 2 or 3 minutes just to give their comment in relation to technology and quality in the spirit of looking at telemedicine with also the new act on digital health. So how do we see the impact of quality in when we introduce technology? So I will start from the far end as we come to the last person who will be Dr.
Service delivery level. So at the Ministry of Health level or at the country level, I think what is most important is the direction that is being given. And in that direction, generally, the involvement of stakeholders to ensure that that quality that is envisioned or quality that is defined, as I've mentioned, what quality means to you and what quality means to me are very different. It's the same as what we discuss in the rights about constitutional rights or human rights. So whether they are absolute or whether they are progressive, and quality is the same. Quality is not absolute. Quality can also be progressive, and so even the best, they always say that you still improve on it. So from this level, it's about then the direction that is given, and that national commitment and direction towards some standard of quality that must be achieved at whatever level. And the number 2 then is what happens on the ground to align with what has been set as the direction. And now, the comment about what happens on the ground, what is most useful at that level, of course, beyond what I mentioned, the environment, the resources, the capacity. The capacity is where HR falls. And HR capacity includes HR competency. Okay, but you can have competent staff, you can have people, but then they don't have the tools, which is part of the capacity. And Dr. Wainaina mentioned about the infrastructural issues and the fiscal space and all of that. But most importantly, in terms of making all those 3 things work, is the coordination. And So you'll find most quality processes is about, most quality projects is about how processes are working together to achieve something. Yeah. And so coming to your question about technology is then, what process have you defined to coordinate these many moving parts to achieve your intended quality outcome? And then how does then technology help you to do that? And technology does two things. It can shorten the processes, it can increase visibility, and it can also reduce resources that you are using. Let's say, especially where the engagement is quite heavy and you need maybe travel times and things like that. But technology in itself does not solve quality. You have to define what exactly you want. You must have all the functions and the decision points that you want, and the things that lead to those decisions, and whether those decisions are giving you a quality outcome. Once you have that decision map, or you have defined in business, people call it business functions. Once you have all your business functions, then now you can have a technology discussion and talk about these processes of mine are 10. Can technology reduce them to 3? And when technology reduces them to 3, is that more expensive? Is that less expensive? And does it get me more quality? As I mentioned, quality is not absolute, it's progressive. Or does it get me less quality? And I think, especially in the context of digitization of healthcare services, certainly there is a lot of value in using technology to improve quality. But the lessons also that we've learned from early digitization projects, especially for the developed world that started specifically on EMRs. So there was a lot of data, but at the service delivery level, there was also a lot of complaints. And I think you've had this, especially in America, in the UK, where nurses, doctors, and service delivery front workers complained more about the need to put in data than the need to see patients. And so it's a double-edged sword when you're looking at it. And this has to be looked at in the entirety. That is why part of also, and I don't know whether Dr. Kariuki would have been here to answer this really nicely, because there's now a guideline on even issues about e-health and telemedicine, because it may improve your access, but it may not give you the quality. Okay? And so I think my summation point is that you first of all must know what you want to do. And once you know what you want to do, then you have to bring in the technology discussion after you know what you want to do, not before. Thank you.
I think for me, building on what Dr. Oluga has talked about in terms of quality, I look at automation, digitization, and technology from a very basic eye in terms of completeness and accuracy of records, be they prescriptions, be they referral notes, be they medical records, because we've had our patients being managed because of the good old handwriting of our prescribers. Then in terms of completeness, we have EMRs that are fashioned in a way that you must follow a certain protocol, you must fill certain places, and not to go to what Daktari has referred to as the obsession with filling the information rather than quality. But I think it's also an important aspect when it comes to having accurate medical records. With the accurate medical records, then we're able to tell the trends of diseases and all that, and we are able then to influence policy based on accurate data. The other thing is that technology is going to help us in terms of parameters referral. We are already doing that, where we send images for reporting in a centralized place. You can take an X-ray or a CT scan from a remote area. We have using a lower CADA technologies, and these are reported centrally, and this has been done very well, at least for Nakuru. We are also able to transmit lab results. We carry the specimen and transmit results without having to move the patient, and this helps in the turnaround time that is reduced. We've also had times when we have collaborated through telemedicine, where we've been guided through, even in theater, to carry out complex operations. And I think recently there was a feature in Makueni. I don't remember the name of that program, but Nakuru carried out the first, it's called wide awake surgery, guided through by surgeons remotely from other institutions within and all over. And as I conclude, maybe the question will be moving forward, will be the role of AI? We have seen AI threatening to make redundant some cadres, but that is not for me to tell. Thank you.
I was hoping that I was being given time to start so that they don't say what I wanted to say. But let me just add one or two that they have not said, because I'll not repeat. With technology, especially automation, it really helps improve on revenue generation for the facilities. And we have seen marked improvement in collections when we now have everything automated. Second, we have also seen efficiency in terms of a patient being seen. The information is keyed in, they walk to the laboratory, they get the samples collected, they go back, and the results are on the screen. I think that increases efficiency in our services. I've also, I just wanted to add on what he has said, though on a different angle. In terms of technology, we are now, in the surgical field, we are now improving or getting on board certain technologies to do certain surgical procedures. A case in point is we are moving towards laparoscopy, where we do minimal access to carry out most of the complex surgeries with improved quality outcome to the client. So I think that is one area that it really has helped us. And we are still exploring so many others so that we engage, we onboard them so that we improve that. And lastly, what I thought was going to be my major thing, but has been said, was in terms of like radiology and even in pathology, we are able to get specimens, and through technology, we get like peer review of the reports, and that improves the accuracy of the reports because we can use technology to engage more human resource remotely to give us more accurate diagnosis.
Okay, thank you. I think it's even worse for me. I think what I would say is, regardless of what is likely to happen, is that technology is here to stay. And it's likely to get even more crispier as we move forward. And this is why I say so. At the moment, when you look at the research in management of very complicated cancers, which at the moment the prognosis would be very low, we have drug delivery mechanisms which are entirely AI-based. So when we get to that level of interaction with technology and the human body, then I would say that the opportunities are endless and they're going to evolve significantly over time. Now, how I would look at it from where I sit is that embracing technology is key, but then knowing what the technology does for you and the risks that it exposes you to is also key. So as we are developing technology systems, we need to look at how resilient it is to the risks that are there. I might not be a cybersecurity expert, but I'm aware of a situation. It's actually one of the big cases that one of the significant healthcare providers in the US, they're usually called, they are the ones who mediate the issues around supplies. It's just because of technology. So it makes a significant, it presents a significant risk, but it has very good benefits if very well managed. From the health financing space, I think where we are going is in terms of automating most of the processes. I'm saying most because we have to appreciate that at the end of the day, we will not be able to automate everything. We are still having that leeway that 20% of some of those processes might not be entirely automated. Then once we have those commands, then we have some good level of machine learning and analysis of the big data. Because that means we'll basically be having 4,000 or 5,000 transactions in an hour. So how do you manage that? And how do you make sense of whatever is coming in? I'll give an example of what Japan has been able to do with the data. They were able to roll out their UHC programs more than 50 years ago. At the moment, what their level of analysis is on the life series data, so that they can predict that if the mother at the point of antenatal care was exposed to malnutrition by the iron, what is the likelihood or what conditions is this baby who survived that pregnancy going to have 40 years later into their life? So that's the kind of big data analytics that they are able to do. And I think there have been several published studies, including in Hungary, where they were indicating that when a mother is exposed to malnutrition, the baby survives and they live to 40 years, the probability that they're going to have diabetes or metabolic complications is going to be 6 times higher than a mother who was not exposed to malnutrition. I hope we are going to be able to get there in terms of visualizing. And from our perspective, I hope I'll be able to tell you that by 2100 year, this is a much that healthcare systems in the country are going to cost. Thank you.
Yeah, just one addition that I've let, and then it's something that we are grappling with, and I think Dr. Kuhara has alluded to it in terms of technology adoption, and the fact that technology is here to stay. So what do we do? And because we are in an institution, Kenya Medical Training College, which is really the largest arm's length institution of the Ministry of Health. So we think 2 things are very important, and one is the digital literacy, because there is quite a huge gap in terms of literacy. And most of us think that we actually do know how to use phones and computers. But when it comes to proper technologies, softwares, or the solutions that are really important for automating or putting our healthcare system at the pipeline that produces the quality, then we really need a lot of digital literacy. And that's a point I wanted to emphasize, because we are in an institution and there is a lot of health workers who are grappling with the change. So healthcare changes quite quickly, and technology also changes quite quickly. And for most of us who are seated here, for example, and being health professionals, we know over the last 10 years how healthcare specifically has changed in terms of the biologicals or the products that we are using, you know. Things becomes obsolete so fast. If you are in the field of HIV, which I think most of us are familiar with, the ART that we used to use in 2014 is no longer the regimen right now. So healthcare itself is a moving target in terms of there are a lot of molecules that are coming into the market. Now we are dealing with antimicrobial resistance, and there's a lot of issues in healthcare itself. Now then add technology, another moving target, okay? So today you're dealing with systems as they were, EMRs, and then now we are dealing with health management systems, and now we've moved to AI, and now people are talking about a lot of blockchain technologies and health information exchanges where now hospitals are now supposed to plug in and have all of that information available. And so the level of literacy that is needed for that ecosystem, and then the level of change management that is needed for adoption of all of those things would be of interest to an institution like KMTC.
Okay, thank you very much for that fruitful discussion. Now, because we are constrained with time, I will have now to move quickly to accessibility, and then we talk about affordability. And then probably when we have a few minutes that will be remaining, I'll allow the floor to have comments, because it's not only the panel who have something to say, but just to dive in back to accessibility. And this time I'll start from Dr. Kuhora. What do you think are the most common barriers that have affected accessibility, especially comparing the rural areas and the urban areas? And I request the panel maybe just to give their discussion, summarize if it's possible.
Okay, thank you. In terms of barriers in access to healthcare, I think one of the key challenges that have been there is the need and the investment history that has been there. We took some time to do geomapping of more than 6,000 providers in the country. And then we looked at the population and did heat maps so that we look at the region in the western side of the country, how many specialist hospitals do they have, how many primary healthcare providers do they have, and there's a significant difference across the country. The areas which are in the arid and semi-arid lands and the ones which have had low GDP per capita over time have a significant low investment in healthcare services, and that presents a barrier when it comes to access. Then the access is not just about the physical infrastructure. I think we have talked quite a lot about the human resource and the challenges that have been there. And then the other bit is on not just the service, but the quality of the service. If you look at the service providers who are able to offer the more recent technologies, they are largely in urban areas. And put it into perspective, one of the benefits that we are having, 83% of the providers are actually in urban or peri-urban areas. So access becomes a challenge. And for it to be overcome, it becomes a cost, an indirect cost to the healthcare system, because this person has to incur a cost to be able to access that healthcare. So yes, there are historical issues regarding the kind of investment. There is a service need analysis data that has not been done across the country to inform some of these investments. And I would propose that in moving forward, I would suggest that we basically look at the Netherlands system. From the 6 different countries that I've looked at, I think it's the one that mostly corresponds to addressing the needs that we're seeking to address locally. Thank you.
Thank you. I will now want to hear from a provider's perspective. What do you think are the socio-economic problems that individuals face that hinders them from accessing services, and how do you think we can improve on those factors?
I'll not talk about the cost implication. I think Dr. Kaura has already mentioned that. But I just wanted to say something about that access bit from the public aspect. There is something called knowledge, attitude, and practice, and also called the health-seeking habits, that also hinders access. And there was a time we were doing some study on a disease called interception. This is a surgical problem in children. And we were trying to look at how long it takes a mother to bring the child to a health facility with that disease. And we realized with a lot of misconceptions and all those things, people will go to look for services away from the health facilities. So that is one aspect in having prompt access. The second one is also the perception that the public have towards a particular facility as a provider. And here you'll find there are some situations where a patient will move several kilometers to get care far from where they come from, because on how I'm talking as the providers, we get perceived by the community. So I think there is the element of how we also do our work, how we market ourselves, and how they perceive us. That can also be a barrier to the access for the care. Those are enough for now.
Thank you very much. Now, from the county perspective, how do you think you've contributed to access?
Thank you. Well, in addition to what the rest have said, from the county perspective, at a time when the leadership of devolution likes to be associated with physical infrastructure, I think physical access has really improved. Almost every village during public participation wants to build a dispensary or something like that without considering whether it adds more value in terms of the services, or it's just like the one next door. In terms of physical access, again, in terms of roads, the road network has continually improved. So I'd like to make my point related to what Dr. has said, and I think the biggest barrier is actually health education. Health education influences or the awareness or literacy of the population. When I look at our competitors, if I may call them that, in terms of alternative medical services providers, be they those, I think a good example is the Babu of Loliondo. When you look at you profile the people who used to go there, they would range from people who would walk long distances to people who would fly. And probably it's because of their perceived benefit of going and taking that concoction. And even when you look at our religious people who sometimes are actually providers of alternative services. And maybe more as we head towards digitization, the issue of information distortion. When you look at what is trending, I think the last few weeks has been the issues of vaccinations and such. Those are very potential, huge. We have huge potential in terms of creating a barrier to essential service delivery. When people talk and make viral, distorted messages, I think moving forward and in the future, that will be one of the biggest barriers to access. Thank you.
Finally, from the national level, let's hear what policies,
strategies.
So,
I think, of course, health access is a big indicator when we're looking at UHC. So first, in the bigger frame of UHC, health access is a big indicator. And of course, at that level, then you're looking at the health facility density per population I think now in Kenya we are doing 2.4 per 10,000. Then we are also looking at the time it takes for somebody to reach that facility. You could be very near a facility, like in Kibra, for example, but there is no open access road or there is security issues, and so you can't reach that facility, even though it's very near to you. And then, of course, the third point is what services are available in that facility. And I think especially for reproductive health, because reproductive health forms a bulk of also indicators for what we call the health of the healthcare system. And I think you know that we measure maternal mortality, we measure neonatal mortality, we measure lifespan, we measure health worker density, and we measure health facility density per population. Those are the key indicators of what we call the health of the healthcare system. And so access cuts across there. And at that level, then we talk about the 3Ds. And I think for those of you that are there, have heard of the 3Ds. So one is the delay to decide. The delay to decide is what my colleagues have talked about. And it is influenced by health-seeking habits, by perception. And one of the greatest barriers of lack of access is what we call poor perception of services, because it delays the decision for somebody to decide that I need a health service. Then the second thing is the delay to reach the facility. And those are structural issues around roads, around security, around transport system. So you may have the roads, but do you have a transport system? Is there a bus that passes there? Is there a taxi? Is there an ambulance? So the delay to reach the facility. And the third delay is the delay to get the service. And so the delay to get the service is whether first you've gone to a facility that does not have a service. Then it loops back to the delay to decide, because I went here when I had a headache, but they didn't help me. So the next time I am thinking, should I really go here? That's why you find people now passing several facilities to another one. So then it now impacts again on the second delay, the delay to reach a facility. Okay, and then when you get there, you get a delay to get a service, because then there is too many of you who decided to go to that same place where, that's why Kenyatta National Hospital is crowded, that's why Mbagathi is crowded, because the facility in Langata is empty, and because people have decided that I cannot get help here. So it becomes a vicious cycle. So we call it the cycle of the Ds. And that cycle of the Ds is, it really summarizes everything around access to healthcare, and then it impacts all the indicators that we use to measure the health of the healthcare system. And now, specifically for UHC, because we are looking at the population that can access a service or a basic package of services that we call universal. Whatever we have defined as universal, how can people access them? Then you come back to this looping cycle of the Ds, the delay to decide, the delay to reach the facility, and the delay for the facility to get you the service. And partly is what Dr. Kuhora mentioned. You get to the facility, either they don't have the service, or they have the service, but the service is not quality. So at the end of the day, you know what people get is my experience in a facility and whether they solved my problem. So either patient experience and patient outcome. So when you look at, now we're going back to quality, those patient experience, patient outcome, patient experience, patient outcome. So how did I feel when I was in that facility? And did they actually solve my problem? So if they did not solve my problem, again, that's an access issue, because you actually did not get the service you intended to get. So I think that is really from the level at which we are looking at it, and at whatever level, then of course there are strategic issues, there are policy issues, and then we work very well with the county governments to look at now the access from a physical perspective. And county governments have always patted themselves on the back in terms of improving the access, and for sure the health facility densities have improved markedly over the last 10 years. But have we improved the overall access to health services? That's a question for discussion.
Thank you very much. Thank you also for linking access to quality, so that we see how each impacts the other. Now, I would like to open to the floor, at least to get comments, questions in relation to quality and accessibility. 3 comments, questions, additions. From the private sector point, how do you think they should partner to enhance access, to enhance quality? I think we've heard a lot from government. Let's hear from private sector. No comments from private sector? Yes, there's someone behind there.
Maybe I will not talk on behalf of the private sector, but it's more towards matters quality. Quality is a very broad-based kind of an environment. Everyone will have their own very different perspectives, and the economists would actually just solidify that fact. Now, coming from a private insurer, we are more in tune and we want to know where is this value coming from? How much of this value are we getting for every shilling or every dollar that we actually pump into that particular environment? Now, as a result, I got so excited when I heard about P4P mechanisms, payment for performance, best practice performance mechanisms and the likes. And personally, I feel as though that is one of the areas that should largely be focused on so that we can be able to get value out of the care that we give. Because when you come to think about concepts such as supply-induced demand and other factors that make the market collapse for one reason or the other, it's very difficult to point exactly where this is coming from. So transferring risk equitably amongst the various players, service providers largely holding part of that risk will come quite in handy when it comes to matters quality and how we can improve on this moving forward. Thank you.
Any other comment? Okay. No other question? Now, let's move to the last part, which we are going to discuss healthcare affordability. And this, I will start with Dr. Kuhara. Do you think social health makes it affordable? When a country rolls out social health, does it become affordable?
Okay, thank you. The straight answer is yes, but it's not the only factor. There is the affordability to the membership, and there is the affordability of the system. So we have to look at it from those two perspectives. Now, to be able to achieve both, then we have to integrate the concepts around the social insurance and integrate it with strategic procurement. So the strategic procurement responds to what the population needs, where they can access it, how much is being reimbursed, what needs to be gotten from the system, and what do you monitor and learn over time. Once you integrate those two, in my opinion, that's where we are going to adequately address the aspects around affordability.
Thank you. Next, Daktari, how do you see health providers can reduce out-of-pocket spending?
Yeah, I agree with the comment that with the social health insurance, affordability is actually improved. And especially when we are going in line with the UHC and ensuring everybody is covered. But there is some small hitch surrounding it. And for us who have been on the ground from 1st of October, the lack of synchronization of the services against financing What do I mean by this? From 1st of October, we said everybody goes to level 1, level 2, 3. As it stands, especially in the public health sector, the level 2, 3 are actually basically non-functional in terms of the human resource, in terms of the commodities. So our patients will go there, get nothing, and will be told to go to the next level. So yes, it addresses the issue, but this should have been sorted before we go to the next level. That's my, and then coming now to us, level 5, 6, I think, and 4. Our experience, the last few days, we have an influx of patients. They are able to register on SHA on the spot, and we are able to admit them. Our supplies exhausted. We are still forced to send them to buy these drugs. You see, these are the things that really causes this confusion and the apprehension that the public is having. But the system, from our point of view, will address this. I know we're still just having the teething issues, and later it will pick. But you remember, even the private sector are struggling with managing their debts that are owed from, I'm not going to continue.
Now, let's hear from the county perspective how affordability will be impacted, probably looking at the Facility Improvement Act. Do you see any impact from that law? How can will it make the cost of healthcare cheaper for facilities? Because now financing is coming directly to facilities.
For me, from a public health perspective, I think SHA may not necessarily make healthcare affordable, because we'll only be transferring the responsibility from maybe out of pocket to someone else paying. For me, the solution would be in embracing health promotion and health and preventive health. There is no way curative services, rehabilitative services will be cheap or affordable. But if we are able to follow what is the current direction of government, where we embrace the primary care, the primary care systems, and in terms of also the healthcare from the households through the level 1s and all that, we embrace prevention, then we are able to ease the pressure in terms of the resources needed, so that those few that inevitably require medical care then can get that care from all of us pooling the resources. But I don't think it will be any cheaper in terms of now that we have SHA. Otherwise, we'll all be careless, and because there's someone paying for it. Thank you.
And now the hard question to the national government. How do you see we can control costs to make it affordable?
Yeah. First, I'm not so sure whether people want a discussion around costs, because one of the biggest pain points has been on the health benefit package, and I think my colleague conveniently did not talk about that, because in the public domain, I think there have been some negative sentiments around, especially the one that I think I've seen going around is the 2,000 shillings for dental cover per year. So the question she is asking is exactly about that. How do you control costs? Because you, the members of the public, want government to say that your dental cover will be 100,000 shillings, right? Yeah? But you also do not want to give more money for that dental cover to be 100,000 shillings, right? True or false? So that is the point of discussion. Okay? And that's what you need to discuss with your hearts. Then after you have agreed with yourself, bring it to the public. So you want your dental cover to be 100,000 shillings, but you don't want to pay for it to be 100,000 shillings. Have we started the discussion or not? Okay? So you've asked, how can we control costs? There are only 3 ways of controlling costs. One is what India has done in terms of a pricing policy. And a pricing policy that goes all the way from subsidizing manufacturing to subsidizing taxes for importation of necessary equipment to training of healthcare workers in large production so that the HR cost, which is more than 50% of the cost in any healthcare delivery system, whether you are in the US or England or Bangkok. So there is not a single day we will ever stop saying that HR costs are high. And I think county government specifically should stop talking about the HR cost. It will always be high. So if you want to deliver healthcare, just know your largest cost is HR, full stop. So we stop that discussion there. Okay? So then how do you make sure you're producing HR? How do you make sure that it's the right quality? How do you make sure that you design the work in such a way that it gives you the result? Those are the cost elements that we are talking about. The products. Kenya right now is one of the 4 pillars of UHC, and I hope you know the 4 pillars. One is on digitization of health. The second one is on health financing. The third one is on HRH. And the fourth one is on commodity security. So commodity security, the biggest focus right now is on local manufacturing. And the target is that 50% of all our products should be manufactured locally, okay? Of course, it has some other value chain issues around creating employment and such. But because in the whole of Africa, 80% of all products are imported. So first of all, we are in an economically constrained country, right? This thing is manufactured in China or in Pakistan, where most of our surgical equipments are coming from, and then, or in the UK or wherever. So the guys who are manufacturing it in the UK or in Pakistan, they sell it. When they are selling it to the next door hospital, it only takes a piki to take the thing there. For it to get to Kenya, you have to ship it. Then there are clearance costs and all of that. So our commodities, ideally, are 50% higher the cost than they're supposed to be. Why? Because you have to bring them here, and somebody has to put a markup. So that's why local manufacturing is thought that it will reduce that cost, because you are taking it from industrial area to Nairobi hospital. The question is, do we have the capacity to produce it? Do we have would we attain the quality that is required, okay? Or do we compromise the quality? Because that also India has done. They produce some things, but they have compromised. They have said, this is for us. So these are serious discussions that from a policy perspective, and especially intellectuals like this, you must have it, because we can't have our cake and eat it. Am I in the right track on this discussion? So, from government, 2 things. Protection from financial harm. Okay, protection from financial harm. So first, who is at risk of financial harm? Financial harm means the person who seeks services and have to sell their goat, their shamba, have to extremely become poor because of health services. So who in the population is this person? How do you protect them from that harm? Okay? Now, after you discover how you want to protect them from that harm, then you come to what resources do you need? That's where health financing now comes in. And on that, there are only two models. One is either you fund it from taxes, in which case you tell people your VAT will be 18% from 16. And you take that money and you take it to protect people from financial harm. Or the second is you do social insurance, where you tell them you'll be paying 2.75%. So the question is, which one is higher or which one is lower, or which one do wananchi want? Which one have you negotiated with them? Okay? Our model is social health insurance. That's the one that we've gone to. In the places like Canada, UK, they have gone tax-based, you know. So they fund the NHS, and you can argue with the government on how much, whether they have increased tax by 1%, by 2%, by 3%. It's the same discussion. The money is still coming from you. The question is, what is the modality that is easier for the government to take the money from you, okay?
Thank you very much. That's why we spared the hard question. Now, just now, as we come to an end to this discussion, I will allow our panelists just to have their last remarks, so that now I can hand it over back to Dan, starting with Dr. Kuhora.
Okay, thank you. My perspective on the 3 pillars is that this is where we are going to be able to change from health sector to health systems. What I mean is that the experience that we are going to draw from this on the rollout will end up being the walking billboard for the healthcare system. Let that patient who had no hope of surviving be the person who is talking about how the healthcare system is working. That is your walking billboard. Let that mother who, if there was no intervention, is likely to have lost that child, be that walking billboard that is telling you your healthcare system is working. And when that happens, it transforms from a sector to a system intervention. We need to get to a point where we can sit down with Sakaja and tell him, look, we need walkways in all the major streets in Nairobi, and when we do that, we are going to reduce the number of cases that are related to this kind of condition because of the urban planning that you will do here. We need to be able to sit down with, I don't know which ministry is currently handling climate change, and tell them that by doing this, you're going to reduce the risk of flooding in this season, and when you reduce the risk of flooding, this is the impact that is going to have on the healthcare system. That's what I envision when we achieve these 3 pillars. Thank you.
My parting shot is that SHA is the way to go. And as from our perspective, it's the best way to ensure our population get access. The only thing we need to do is how to be able to address the issues as they arise. And here, you know, we have to appreciate from both sides, the provider, the payer, and the rest of us, that we should be able to address the issues as they come. And I think that we can end up with the best system that can serve our population.
And for me, from the county's perspective, I would like to thank Kmtc and the organization of this meeting for including us, even if us means one person. So I would like to see a bigger representation of the counties where the bulk of the health services are provided. And to Daniel, thank you for the ambush.
Yeah, I think even for me, thank you so much. I think Kmtc as an institution is one of the most useful and I think also matured in terms of production of human resources for health. Nearly 90% of mid-level HR have been produced by this institution. And then so in terms of the impact of on the system, I think the Kmtc has a permanent mark on that. The thing is that the more that you do, the more that is demanded. And with the changing targets in terms of the quality of HR that is needed, I think there is a lot more that is expected of Kmtc, even on that market. As we discuss quality, I think there will have to be a bit of your internal thinking in terms of how do you want to address those challenges, because you are the factory for the market. So what the market is saying, how then do you internally review to respond to what the market is saying? And that's my parting shot. Thank you.
Okay. Thank you very much. I would like to thank again the panel for sparing time to come and have this fruitful discussion, even for those that we ambushed. Thank you for rising to the occasion. And also thank you to the participants. At least I hope this was a fruitful discussion. And back to you, Daniel. Thank you.
Thank you, Fardosa, for the well-moderated session. We will break for lunch in a few, but okay, this panel was quite serious, and it's doctors. Do doctors eat? Now, let's throw in a human, a non-doctor question. We always remember our last meal that we ate and we seriously enjoyed. I remember mine, and it was sometime last week, and I went to visit someone in the office, and I didn't know there are people who cook in the offices. And we were served with some very nice ugali, green managu, and it was milky. Then the meat, it was a small portion of meat, but well done, and it was soft. Dr. Kohora. And as we go, then our moderator as the last. You don't have to be the cook, because now that we might say we didn't eat. You can share the last meal, one of those meals that you remember to date.
I think you've mentioned not just about food, but the one that was well done. Some of us might be used to mashakura, but I would say not so long ago, just about 2 weeks ago, some omena that is differently made, totally different. You wonder whether it's real omena or it's some other type of species. And made by a team that was hosting a Kenyan delegation. And well, ended up being a very good discussion. And it stops being about health systems and becomes, which type of fish is this?
Where was that? So that we know. The mic has quickly been passed over.
Well, non-disclosure agreement.
Non-disclosure. Agreed. Professionalism adhered to. Dr. Ngonga, I'm watching that mic pass.
Mine is long time ago, and it is, I don't know whether Kaura was just thinking or reading my mind, but it was also mena with milk, and also the ugali was the brown ugali made from wimbi, and a bit of, there is this mboga, we call it, what? Managu, eh? That was the one. And it was long time because it was made by my mom Well,
We are to talk about our favorite meal.
I like that surgeons don't talk much, but when they talk. Yes, Fadosa.
Mine, I don't know if it was a very good meal, but it's a lesson that I learned from food. I'm born and raised in Kisumu County. It's just after that I visited other towns that I discovered fish tastes very different. Does not taste the same.
Better or different?
I would say different. So there's a different taste. If you come from that side, you come to realize that fish does not taste the same in the other areas. Thank you.
Okay. Dr. Wainaina.
I think it's turning out to be a fishy affair. So maybe I share my fish experience. On January 4th, 2020, just before COVID times, I took a tour to Budalangi. We stopped by a place called Mundere. Then we were served with some very well done fish, but with some very good sticky ugali that you needed to apply some sauce before you, some techniques. And I was full till the next day.
Yeah, but I think you're just talking about unique moments about with food, right? Yeah, so mine was this morning. I was in the office and I had a guest, and my guest is a Mzungu, was a Mzungu, and so he mentioned to me that he once was in Kenya in the year 2000, and there was when he was working around Nambale in Busia, and he enjoyed mandazi, and he hadn't eaten mandazi in a long time. And so I requested our secretary to just go get us 2 mandazi and make for us tea. And we actually really enjoyed it. So I am sorry, together with other things, that's partly why I was late. Thank you.
So let's hope media does not misquote and say Daktari was late eating mandazi. So I think we can, we were doing 4-factor or 3-factor previously. 3-factor. Now we have 4 panelists and our moderator, so we can do a 5-factor as they take their seats. We have now mastered the act of the factorial clap. So let's go. Thank you very much. So we will break for lunch. Then after lunch, we will have our last panel discussion, which thereafter we shall now be joined by leadership from the Ministry of Health, our mother ministry, both institutions here. And lunch will be served on the ground floor. But before we leave, let's kindly pick our lunch vouchers from the registration desk. And yes, it is prudent that we pray for the food before us, before we eat it. And I will request for a volunteer to offer a prayer. We have students in the room. They have not talked the whole morning. One of us. Thank you, sir.
Thank you. Can close your eyes. Thank you, dear Heavenly Father. We give you praise, thanks, and adoration, God. Thank you for the good progress that you have given us, Lord. As even you are continuing to, we are going to take our meal, Lord, we pray that you may sanctify us and make us true, God. And at the end of everything, all, we shall praise you and say thank you. Thank you for the experience in this moment, Lord. I'm humbled. Thank you for that prayer. Amen.
So it actually hit him later when people are laughing. Yeah, it hit him later. I will see. But of course, he had intended it to be funny. I'm going to feel out of that part. Yeah, I know.
Gonga mswa, okeli gonga mswa. Gonga mswa, okeli gonga mswa. Gonga mswa, okeli gonga mswa. Gonga mswa, oche amani gonga mswa. Che amani gonga mswa, che amani gonga mswa. Gonga mswa, oche amani gonga mswa. Gonga mswa, che amani gonga mswa. Gonga mswa. Ukenya gonga mswa, gonga mswa, Ukenya gonga mswa. So now ukiitwa unakuja na wapi? Na mtakele ametuonesha, si ndio? So that's the style. Hiyo ndio style ya hiyo wimbo. Mwana mberi bayaye, bayaye we. Mwana mberi kicheko. Mwana mberi bayaye, bayaye we. Mwana mberi kicheko. Mwana mberi ni Kenya, ni Kenya we. Mwana mberi kicheko. Mwana mberi ni Kenya, ni Kenya we. Mwana mberi ni kicheko. Now I've done some for you. Now when that time comes, sisi lioness. Namna hiyo. Asante sana MC.
A clap for the team. Okay, a clap for the team. Okay, Florence, a clap for the team. Tutaanza kutaja watu majina. Okay. So welcome all. Okay, let's wait for the So as we start our afternoon session, we would like to recognize the presence of PS Health Representative, Dr. Grace Ikaho. There are those who joined us during the morning sessions. We would also wish to welcome you. And well, welcome, enjoy. We are getting into our last panel. Last panel has been discussed from, issues regarding the last panel have been discussed from the first panel discussion, digitization. And the last session, the last panel, it was a full house government panel. When it comes to digitization, private sector or government? Private or government? Both. Neither nor. So I will invite our fourth panel. The team will be looking at digital innovations in health insurance. And I will start with the team moderator. The moderator for the session will be Dr. Kennedy Akumu. Dr. Kennedy Akumu is the CEO, Health Solutions and Digital Health Consultancy. Dr. Akumu, karibu sana. Center seat is yours. And his first guest, to his right, Dr. John Muthe. Dr. Muthe is the CEO Health Savannah Informatics. Karibu sana to the panel. We have Ms. Faith Ndongo. Ms. Faith Ndongo leads advocacy and communication at the Health NGO Networks, what we refer to as HENET. Karibu sana. Mr. Anthony Lenayana, the CEO, acting CEO, Digital Health Agency. He's a not usable person. He's not here. If he joins in, he will proceed. Dr. David Mutinda, CEO Healthix. Dr. Mutinda, left or right? Then we have Dr. Peter Gekonyo from Equity Bank. Karibuni sana. So full house, private sector. And civil society, I am corrected. So, Dr. Akumu, the mic is yours. Take over the session. Thank you.
Good afternoon, ladies and gentlemen. At first, I was wondering who is Dr. Akumu, and it is Kennedy Auma. So thank you very much. Now, this afternoon, we are going to look at technology and the role of innovation in health insurance. Up to speed, I know these are able ladies and gentlemen who are not only teaching but practicing the same thing that we are talking about. When it comes to examples, they'll give us real-time examples of what they are doing in their facilities and in country, Kenya in general. We are talking on health pillar, health financing. And this is where we have been brought here courtesy of the students who are learning health insurance management. So I believe this panel is equal to the tasks. So they normally say ladies first. Amen? Amen. Yes, with regards to HENET, you have a coverage of the whole country. You have a big membership. And they utilize digital health space quite a lot. So will you kindly advise us and help us understand how your members will use health innovation in terms of reducing waiting time, seeking health activity and services?
Okay, thank you so much. And let me start by appreciating that civil society are considered and part of this conversation, in that civil society is the bridge between the voice of the person and bridging in into the experiences that the people have, but also grassroots innovations. And at HENET, yes, we have a membership of more than 100 non-government organizations as our members. So in terms of experience, I would say that we've seen a lot of transformation in the digital space when it comes to health, from a point where everything was paper-based to a point that you're told, move to the next room. So those are innovations that we are seeing that you don't really need to, when you're going to a health facility, you're given a paper and move with it away, then that means that you have to go back and say, I was here and I don't know what I was sent for. So that's something that I would really appreciate, just from the aspect that you can move, technology has been used just to ensure that when you're moving to the next stage, already your details are in the next stage. And this is happening in the public, but also in the private hospitals. I would also say that also in terms of waiting time, we have a lot of conversations and reminders which are coming in. You'll find that, especially with the private sector, there are reminders for immunization, helps a person plan and program. But I've seen also a lot of that happening in the SMS reminders, also in the public sector. So those are things we can say are innovation, and from a civil society and community point, we really appreciate. Is it optimal? Probably can be made optimal and consider far too rich areas, rural communities, and areas of neglecting, because at times programming focuses on urban areas more than the rural community. But I would say there's been a lot of advice, but also have that feedback and engagement to the providers.
Still on the same note, we recently got some SMSs from SHA. Would you tell us if your members would be interested to see this coming from the insurance sector? That this is how much you ought to pay, this is how much you've spent, since you have a big...
The elephant in the room, data protection. Who gave my information and why am I being moved? Who authorized, you know? So that's a real conversation which we need to look into and ask ourselves. Even as we advance in technology, how are we handling this data? Who's getting my data and moving it and sending that communication? But beyond that, some of the things that both SHA and also the private sector can embrace is getting feedback. Because many are the times that we go to health facilities because we are sick. But then there is the rest of the year we are well. So we can engage and get feedback in terms of how can we serve you better? What services can be introduced? And so we can use the same platforms to provide information, even on wellness, just telling people about breast cancer awareness, cervical cancer screening, and also beyond that, just to get what is your customer experience, because rarely do we ask what was your experience when you're seeking healthcare, and especially when you are well. So those are things we can look at, but also considering and looking at matters around data protection, and also the fact that even when you engage in me, there's need for that prompting so that I click in to show that I'm interested to go to the next stage.
Awesome. David, data security and privacy, confidentiality. Would you kindly explain to us briefly how the blockchain and the Data Protection Act, Digital Health Act come into place with regards to health information management? You can use mine.
Hello, it's working. So GDPR is quite big. First, it's the collection. So are you authorized first to collect the data? Number two, how do you store it? Hata kwa watchman tunaachanga data. The question is, kwa watchman kwanza tunaacha mingi kuliko ile iko kwa hospitali, because your phone is there. Like I know I am an ODM member. Sorry to all the other parties, but I didn't register. They just got my number somewhere and they put me in the party. The question is, now I'm a member. When we were doing that thing for Bonyeza Taturine, I found myself a member of that party. So now I've not rejected. So don't follow me, because that's not where we are not talking about voting. But the question is, your data is somewhere with somebody else. The question is it protected? How many books do we have even when we walk into the hospitals that the guard there, wakitoka waende, who do they leave it with? Yet it's my information that is actually there. So if I went to the hospital and maybe somebody called me from that place, I can actually sue the hospital. I know many of us are not thinking that the hospitals are suable right now, but there's somebody who will get clever. The same way we had ambulance chasers and all that, and they will get clever. So the question is, one, there is collection. Number two, there is a storage. And then number three is access. Who are we giving what? And then when it comes to transportation of that data, when I'm transporting that data from my hospital to actually SHA, the authority when they are supposed to be checking out my claim, what information am I passing? If today you met data that is for Raila Amolo Odinga, how much will you trade it for? Those are the dear questions that are being asked. How are we storing the data? How are we transporting the data? And how are we transmitting? And definitely also the transparency around me. When I want you guys to forget me as a hospital, then you are requested to forget me. Even an institution, you are allowed to forget me. Even when I'm enrolled in SHA, did I opt in? If I've not opted in, then you're not allowed to say that you actually know me. So those are some of the questions and concerns that are actually there with GDPR.
Thank you, thank you. Now, this question then goes to Dr. John Muthe. Your facility handles patient information, you handle claims management, and you store patient data online, right? Now, how will artificial intelligence and machine learning be used in claims management and adjudication?
Thank you. Yes, we offer the Slate service across the private insurance, we're in the room, and also SHA. And I think when you look at the industry across the last maybe 15, 16 years, there's been heavy digitization early on in the HIV programs for public sector, followed by the private sector, the billing processes, followed by the electronic medical records, and right now a lot of digitization in the public sector. So it's amazing. But then it means that now there's a lot of data being produced for every single transaction. Typically, a single transaction has almost like 4 SMSs, 1 or 2 fingerprints, and provisional diagnosis, final diagnosis, diagnosis 1, 2, 3. It's a lot of data that is very fast, the rate at which it's being produced. Let's not even go to pre-authorizations per hour. So on the other hand, we are seeing the compute infrastructure also improve very fast, and it's coming in a box either from Amazon, Google, Microsoft, and it's very cheap to process a single transaction. So I predict in the next maybe 10 years, the diploma that we're even speaking about today, most of the classes will be about how AI is used, especially in claims processing, because as SHA moved from 15 to 55 million people, we can't fit all those approvers in the SHA building. So the one place that we can find help in the coming years is the ability, first of all, to predict which population is most likely to get unwell. And as we said earlier in preventative, then instead of waiting for the claim, we set the health education. And that's a good idea, that we know that you are most likely to have a diabetic visit. Since we know you're diabetic, please check your diet on this. So the first thing is going the reverse way. We'll have ability to preempt the claim before it comes. Then once the claim comes, it's the speed at which it will transverse across the decision points, the human ones, also the machine ones, with a lot of knowledge, knowing that, as I was telling someone earlier, that we know that this is John. John has had diabetes, then got renal disease, chronic, and has been on dialysis. Most likely, he likes KNH. The claim is 10,750. We have been paying for the others for the last 6 years. We have to give reason why this one we won't reject. So we'll be able to segment the ones that require heavy surveillance, better QA, and then focus on those more. So I see the speed at which we do things, the speed at which we take advantage of all this new incoming data, and also importantly, the speed at which we coordinate across the industry so that the two employers or two insurers can coordinate with SHA and be able to say that this one is fully paid up to this allocation, and I think that's the beauty of the future. Thank you.
Right. Okay, just give it to David.
Just a comment around technology. Number one, I think we are going into AI, ML, but our teachers, are they teaching with computers? Are our students knowledgeable in the computers? What is the institutions doing to ensure that everyone is actually computer literate and ready for the market. Because the market is unforgiving. I'm sorry. Nurses have to come in and they have to punch in their data. I can bet you that when you go to Java, that girl just scribbles a few things. But trust you me, she does not have the luxury of actually bringing a meal to you if it's not captured on the system. I know the last panel talked about a few of those concerns, and I was a little bit concerned, seated there saying the way the technology, and let me break down technology. I think just a little bit. An MRI is a technology, but a system that allows an MRI to exchange information with the system that you are paying with, that is a different technology. And we have to be able to be cognizant that when we are buying the machines, we've not bought all the technology. The digitization and digitalization is critical and important, and especially for the students who are coming into the market. They need to understand that particular journey, because for me as a business person, I'm not only interested in that particular machine that is producing pictures, I'm actually interested in seeing, was there revenue today as I walk home? And the question is, was there revenue and from what disease? And I think that's what he's talking about when we talk about the claim management. I think we were just exchanging ideas. We developed the first document for claims management in 2016 at Nairobi Hospital. I know it's been shared across multiple hospitals. And the question we were asking ourselves was, that information, how has it translated to value to the public sector? Because right now we have tools, like one of our tools that we use is actually using AI in Nepal. And we are running claims management in Nepal. But in my country, I wouldn't run it because there's quite a bureaucracy in just being able to access some of those integrations. And also, there's tools that are available that are easy for the students, that they can actually be able to latch on. And when we talk about, I think that particular course that you guys have developed is actually very primal. Because when you look at insurance, they want that particular person who has an ability to see insurance, to see money, to see healthcare, and to see technology. And if they are unable to see those integrations playing together, then definitely you lose out on share. And the client is not looking for any other person. They're not looking for the nurse. They're not looking for the other party. They're actually looking for a skill set that is very different and needs to be there. But when it comes to AI, ML, there's a differentiation. When something can package this water, that's a particular specific AI, almost like machine learning. But when it can produce this water and bring me also this flower, that's a second level of machine learning. So, and also, we have to be able to know what is coming to us. I think when Sajan was talking here, I truly appreciate what he was putting together, because he's basically saying, for me to be peer-reviewed, there has to be other systems that are talking in Nairobi where I can send that image and my peer review on the same data that is being generated by hospital A or hospital B, and the peer systems can actually be able to discuss. So those questions, we need to be able to address them and also bring them into the fold, because that's actually going to bring down the claim adjudication process. And let me say, fraud is internal everywhere. Fraud is internal. It's never external. Most of the guys know the systems. The question is, I'm a banker. Initially, my first integration was M-Pesa. When you paid M-Pesa for 2010, GoTV, that's the first integration we did. And the question was, nobody wanted that integration to go away. But the question is right now, when we look at the trends that the money industry is doing and what healthcare is doing, we are not keeping to the speed. So we have to be able to catch up. And this is in the same market, what finance is doing, in the same market, what healthcare is doing in the same market. There's a pace that we actually have to come to. Sorry, guys.
Okay, just give it back briefly to Dr. John as I come next to Dr. Gikonyo. Now, will you kindly explain to us briefly, because according to ACI report, 5 million claims are processed daily, and then 2 billion Kenya shillings lost annually. So at what point in this integration do we lose this?
I think I'll go back to what the first person in the first panel said, that our protocol observes. my customers are in the room. I can only say that
It's
my
taken.
observation is that the private health insurance, I think looking at October, would produce maybe a million or so. Private health insurance, the 18 or 19 of them, about a million or so. And in a month, that's my observation. And I think SHA last month was 500,000 of those. And I think from this month, you see SHA doing more than the private health insurance within a few days. So I think as we go to 2024, 25, I think the output in volume for SHA will be maybe, I would say, a couple of multiples, maybe 3 or 4. So the 5 million you're saying, I think it can only be achieved if we have SHA on that number. We shall take in maybe 70% of those transactions, private health insurance, that percent. Now, in the question of electronic transactions have a very interesting trail. They are known from the beginning all the way to the end, with SMSs to the member, which actually creates visibility, and from visibility they're able to say. Now, where does the bad behavior in fraud, excess, and the like? It's a mixture of things from what the provider wants to do for this particular patient, and that's the one that I hope that in good time protocols will help. I want to give an example, like for the emergency and chronic care fund, looking at the emergency fund and how it's achieved across level 6. You'll achieve that fund because you followed a certain protocol developed by SHA and the Emergency Kenya Foundation. That's how you achieve your claim. You don't achieve the claim by coming outside the protocol. And I think once that is seen as successful, then when we come to the surgical, the medical, mental health benefits, the other benefits, you'll achieve a claim from following a protocol, a guideline. And I think as of the last couple of weeks, we have seen it in emergency care. So I would say that you have to start with the patient, the right benefit at the right place at the right time, and the hospital itself can offer these services and the like. So there have been many rules, but it's by following the protocols, the rules, and the guidelines that a claim is clean from the word go, rather than it being rejected and it becomes a reconciliation issue and friction, and then we increase prices next year to recover what we lost. Thank you.
Okay, so in a nutshell, you're saying that we then have a specific person who will handle this claim from start to end, somebody who will be held accountable, responsible, in case of a fraudulent, in case of a multiple payment. It's okay, all protocols observed. As we move
No, institution
to
institution. Remember the contract between the payer and the provider, not the payer and the provider and the doctor. But when you look at pre-authorization, the doctor and their licenses agree to terms and conditions that they are doing the right thing. So their licensure is dependent. You know, the way auditors, they have to self-regulate. I think we are coming to that level that the clinicians themselves are part of that social contract to the extent that they want to say that this is the right procedure for my patient at this place, and as per my training, I know I can do it. Thank you.
Thank you, thank you. Now, as we onboard clients, Dr. Gikonyo, you've heard that artificial intelligence is here with us. It affects everybody. Now, as Equity Afia grows countrywide, how do you use telemedicine and AI and mobile applications to onboard clients as you move along?
So thank you. Thank you for that question, and thank you, the panelist. I think my question twists the discussion because the presenters on my far left, they are a bit technical, but now I'm shifting to more commercial aspect. How do we grow and how do we move? And generally, what we are talking about, the technology, how does it disrupt the operations? And which opportunities does it create? We can narrow down from where I work from the Equity Bank is due to the technological disruptions that it has grown the span of business, growing tremendously, because you're able to onboard clients more, you're able to offer solutions more, you're able to listen to customer more because of technology. So back to the discussion of the day, because it has been brought in because of the students who are taking the diploma course in insurance, is relatively a good thing because what it does is creating efficiency, creating understanding, creating more opportunities for organizations, including where I work. I would love a situation where the health cranes are being handled by a more specialist staff. And if we can look at this globally to all the institutions, then it can really lead to a very significant change to that. So back to the business. And back to the banking side, back to the equity avia clinics, of course, now the bank, that's why it's the bank, it has also created the insurance arm to be able to handle the claims, and then it has also been a service provider. So I'm looking at it from a 360 degrees angle. There is a banking side, which offers a clientele, there is a service provider, which is equity avia clinics, and then there is the mass market, the 16 million customers whom the bank is holding for, you and me. So the AI, the artificial intelligence or the technology, how does it grow the numbers? First of all, in terms of providing the analytics, whom are we targeting? I believe that the SHA was looking at those analytics and saying that we're going to categorize all the clientele on this number, or categorizing all the clientele on the lead basis. Then from there, it comes to the proposal, who pays who? So the first element is that you provide analytics for you to be able to understand the demographics. You can be able to understand all the clientele and be able to come up with proper products. Then the second element, this is what my two co-presenters have said. When you have the blockchains, you are bundling all the claims together. You're able to identify early enough the fraudulent claims, ensuring that the entire system is seamless and these claims are being able to be paid on time. Then the other aspect is that creating, of course, now once you develop the apps and the like, of course, the onboarding process. I remember the lady from Hennet mentioned about the issues to do with the legal issues on onboarding. But of course, once you use the apps, it's legally abiding because the client was able to onboard themselves and probably even advance more. What am I likely to need? Maybe that apps can be upgraded. I think the tech guys are here. That even at the onboarding process, that I'm likely to enjoy this kind of services, chronic illness and the like. Then from there is the issue of the customer service levels because of the apps, because of the technology. There's efficiency. You're able to pay the service providers on time. The clients are able to be served in the hospitals very quickly. Then you produce a customer service levels which are way above, instead of us relying maybe on the physical documentation. Then, of course, we look at the expansion of digital channels. Right now, where I sit as from the banking side, from commercial, I'm seeing an opportunity. If you're able to onboard yourself, then from SHIF side, from the SHIF side or the private insurances, then from the app, we can even advance and say, if you don't have the money, then what happens? Yeah, so me as a banker now, because my work is to provide money. So after you do the app, then say, am I paying cash? If I'm paying cash, yes, proceed. If you don't have the money, then I come in and I say, can you borrow the 6,000 or whichever, 275? Then from there, the money is credited to the insurance company, and I'm able to proceed. So those are the key essence of expanding the entire service levels. Then we can also look at, in terms of, I talked about the business growth, expanding the risk, the business growth. We can also look at the issues to do with the risk. Of course, now the AI is able to assess that if I'm having this number of fraudulent cases, then the artificial intelligence can be able to identify and be able to flag those transactions maybe way enough. Then maybe the final thing that maybe this is narrowed down with the technology, it's far much easier. Like we have seen the Gen Zs, the generations, they want their products more quickly and more seamless. So what happens in that case that maybe what we call the on-demand products. So what they can go create with the app, they go create, they're able to pay, they say that I'll be paying per day, per week, per month. So the technologies, and it's helping them to be able to make those decisions quickly. And finally, how do you customize? Because you see now the products which are being curated, they can be customized with the help of technology because it's able to assess. This is a need gap, this would need to be advanced, this would need to be upgraded, and from there, the business is able to grow. So I've talked from commercial side, I think that's what I was hit on, and we can see how we can be able to grow the numbers. And I think that is the main question from Shah. How are we able to onboard the largest number of population for the enjoying of these benefits? Okay, so thank you.
Right. Now, as I come back to Mutinda, and then John, and then my sister Faith, we normally say that data iko kwa cloud. Where is our data? Iko kwa cloud. Now, what are these cloud-based applications? And we are training the first lot of students to be able to understand that the data generated will be cloud-based, right? Na huwa kuna kulala, unafanya 24/7. So just like explain to us briefly how cloud-based platforms operate and how we can seamlessly.
How many are on Google? Maybe that's.
Okay, how many are on Google?
How many have a Gmail? It's on cloud. On cloud basically means that there's a company that has chosen to buy servers. Because in the olden days, we used to buy servers, fill them here, then we have to provide what we'd call technology to keep those spaces and those servers running. So there are people who've generally taken that as a specialty, the likes of Google, DigitalOcean, and there are so many out there. And Safaricom here, Equity Bank is one of them. Also, Coop Bank, I think, have their own cloud service. But the question is now you start giving it away. Like right now, if you look through your data, you will see you've done 20% consumption, 15%. I know some of you have started paying for those pictures you've uploaded there. There are some of you on 200 bob already. There are some of you on 300 bob. There's somebody who's buying more spaces. So the question is, that space that you're buying is actually what we call the cloud. The question is, the second bit is on the question of GDPR. Is that allowed in this particular market? The likes of Google and all the others, they've already sought for all that clarification. They have offices here in Kenya. They are given those permissions. They are allowed to do the business here. So now, as a college, or as an institution, are you allowed now to go buy space in their place rather than you having to buy servers? Because once you buy servers, then you have to buy a Mutinda, and then a Mutinda B, and then a Mutinda C, who are actually going to be costs to you as a business because they are going to request to maintain that server, maintain that service, buy a UPS, buy a generator, all those things. So the cloud services give you all that package in one single setting. Then what you pay is a monthly recurring cost. So the question is, the person that you're buying cloud from, are they authorized in this particular market? Number two, are you following the global data protection rules that have been laid out there? And then number three, are you securing your data? Because in as much as it's actually out there, you've bought space, then there are softwares and there's security that you actually have to buy. And that particular software, like I know some of the times you go into an internet page and it tells you this page is not secure. Don't proceed unless you know what you're doing. Huh? Otherwise, you will lose your data and all those things. But the other question is, what about the people who run technology and security as a service? So they can also secure your information out there so that your information is actually not lost. But also, lastly, is what we call design. You design data so that even if you lose one data, you actually don't lose everything. And I can tell you from a bunch of keys. There are keys you have in your car that you know they open the front door. Once you open the front door, then you have the other set of keys for your bedroom and the other spaces hidden in your house somewhere else. That's how all of you think. I'm so sure I'm not the only one who's thinking that way. So you don't carry all the keys when you go outside. You store them in different spaces. So in the same way, design of data is also critical in the way that you approach so that you can actually have your data stored. It's only a homo. You know his number, but then you don't know his medical condition, which is on another page and another table. So those are some of the compliances and things that you do. And that's why whenever you're designing some of these systems, call some of the people in the market. They will be able to give you what you'd call a complete package, and that allows you now to do some of those designs effectively and ones that secure your information now and in the future.
Dr. John, when you have everybody's data and you have our keys, yes, now how would you use this analytics in big data to help come up with better plans for the country? One, to help us know what conditions, like it was said in the morning, you know what surgeries cost at what price. So how would you use big data to come up with this analytics for better tomorrow?
Thank you. I'll talk about a couple of experiences we have at Savannah Informatics. The first thing is on our USAID work, Nairobi Kajiado Faria Jamii is the name, and also USAID Digital Ecosystem Activity with UN. What you're finding is that in especially primary care setting, your biggest worry is this patient you're expecting to come and they didn't show up. You know, you're in Mbagathi, you're in Mama Lucy or Kimana or Loitoktok, you expected these 60 patients. In fact, all of you are there, then they didn't show up. I think being able to predict who who is most likely not to come, and communicate to them early alone on the Sunday, on the Saturday. It's always interesting that Kenya Airways will remind you a lot, but my favorite hospital, the chances of them reminding me as much as Kenya Airways are very low. And the other thing is also immunization, whereby especially for newborns, for children, that period is very critical. And just being able to know that we have to tell this mother, this coordinator to come is very important. All along during tea break, we were talking about oncology, whereby, I've seen a lot of complaints about, let's say, the benefit package for oncology. But the biggest challenge in oncology in Kenya is people finishing their course. I don't know, Dr. Kokor is here, but he can say that the biggest challenge is not how much you say the maximum, is you want this lady to come back for her septin again and again and on time. In fact, people celebrate when a patient finishing their course. And being able to collect all this data across all the 75 cancer diagnostic and treatment center licensed by the National Cancer Institute is what also I'm seeing SHA working on with them, and saying that we need to put our data together so that we can know when this one disappears, have they disappeared to go start afresh somewhere else? When this one disappears, what characteristics can we see in their disappearance and their barriers that now we can share? And I think that's what I'm seeing from all this data that now is available, and being able to have, in fact, you see SHA doing more clinical coordination work because they're able to see the various 75 cancer diagnostics and saying, whenever you see this one, this particular pattern, let all the other cancer diagnostic treatment center and oncologists know that we are seeing a likelihood of dropping out of care. And I think that's the beauty I'm seeing in data, being able to share patterns across the treatment pathways with as many providers as possible, public, private. Also, the other thing that we are seeing, especially in clinical care, is that I think in healthcare we are very impatient, and I always say that no one wants surprises. People want the moment of truth to be the moment of truth, not the moment of goja kidogo. And the fact that trust it has to be earned anytime, whether it's on the enrollment path or the treatment path, there's a lack of trust. It's subjected as the truth, that there's no trust elsewhere. So I think we need to amplify wherever the data shows that we did well, especially in customer experience, in the net promoter score and the feedback, we amplify that knowledge across the whole network. And also using data and seeing that there was a point whereby we disappointed a member or a patient, we use that as a learning lesson and quickly figure out how to amplify that across the whole country, across all, maybe more than 10,000 service providers. And I think that's the thing, that the data that we see, for the truth it tells us about ourselves, we quickly learn from it and be able to impact change. I think one of the things that I've liked in recent times is seeing knowledge coming from the private sector, let's say where we offer it to the private insurance, Jubilee, PA, Britam, and they're in the room, and seeing that knowledge also in the processes also go to SHA, whereby we're working with the team in that. And it's beautiful to say that both sectors are learning from each other, and then the knowledge coming from SHA, especially in fraud, abuse, excess, hopefully, and seeing it go back to the private sector, because most of the reason why there isn't as much investment in products or in the private sector is because of the fear of this excess, this fraud, and I'm seeing a point whereby the government, through the digital agency, and Anthony is not in today, will start sharing this knowledge, this intelligence out there with everyone. So I like that we are in an age whereby there's a lot of data. I see forward to a time whereby there will be a lot of knowledge, intelligence being shared, especially by the team at SHA with the private sector. And at that point, there will be, start seeing growth and investments. Thank you.
Right. Now, in 2020, Faith, we developed a chatbot for COVID-19 for the Ministry of Health, where you are able to type where you are and you are able to seek services. Now, is your facility using chatbot as often to guide with regards to health-seeking behaviors? And if yes, would you advise how will it better be utilized in health insurance?
Okay, thank you for that question. And I would say because HENET is a network of organizations working in the health space, yes, many of the organizations would use chatbots for many different conversations, including, and I'm happy that you raised the immunization conversation. There's matters around reducing the number of children who don't get their immunized. Because in most cases, if you skip the very first session, then there's a probability that the mother feels, kumbe nothing happened to my baby, so I can stay at home. So the first thing is usually how do we then use simple chat boxes where we have messages to the people and engagement, very basic engagements that you know how important immunization is, you know? And that itself makes a person be like, oh, I don't want to be the one who has made my child not be okay. And in many different conversations, including even in the HIV space, we've seen a lot of this happening. And I'd say in the insurance space, it's really, the ground is really good because people look at simple ways of engagement and people feel good when they feel that their views have been listened to, but also there's someone responding. Doesn't matter that you're not seeing who's responding, there's a response coming and come in real time, because the challenge that many people have is, and even with SHA, is when there's that silence. I've enrolled and then I don't know what next. I'm supposed to put in my dependents, I don't know what next. And I'm supposed to move from the system to the website and back. And so it's a matter of how do we make these conversations very simple. And also, you had noticed about this, but also when we're looking at health insurance, including SHA, it's important to place it from a point of the value. Because when it's put to the people from the point of you have to, then many people get to rebel. But the moment I see there is value, then people opt in. And when you look at the commercial side of things, I mean, many people have M-Pesa. How many people are told that they have to be having M-Pesa? And they trust having their money in M-Pesa. And they trust transacting. They never sit and say that somehow something is going to happen. So the same way with health insurance, because it really comes into cushion us and even save us from the M-changas that we are always in. So if we put it from a point of the value preposition, then we can have more people enrolling and more people benefiting. And the moment that we have the people enrolling and benefiting, they are the same ones who use the word of mouth to say that this thing is really good, can you get in it? But before we put it from the point of value preposition, we will struggle to make people join in because they really don't see it as helping me and as something that is good for my life. So it's very important to also see how do we use the digital technology to communicate to people on the value of insurance, health insurance, and also, and especially for the population which we are now trying to get into health insurance, for them to see the value for them, but simplify the information in a way that I know that the person who's elite, but also the person who's not gone to school, can look at the system and say, oh yeah, it's easy. I can easily move to the next stage without feeling that it's getting complicated and I don't know, am I revealing too much, you know? So I think those are questions that we need to ask ourselves, especially on the technology space, but also using the chat boxes, obviously, for the engagement and quick feedback and for people to provide. And whatever inputs that people put in, it's really important for that to be used for advancement and also improving the systems we have.
Ladies and gentlemen, you've heard from the experts. The students sitting behind are learning all these things. Is it a unit? It's a course. Thank you. A question, one or two, for the panelists. They're being taught administration, they're being taught financing, they're being taught technology, and they're being taught infrastructural development and usability on claims processing. 3 years. Question?
Just during COVID, the same thing happened where people were being admitted or you're diagnosed with COVID. And one of the things that we did with some of the brands is to get what you'd call a toll-free line where you could actually call the clients and actually support them. Because a lot of the times, you've seen me, I think he was talking about oncology and I was really putting out the data here. The oncology, 39% got recorded. So 61 got staged, but then nobody called them, nobody found out which stage they're in and everything. So some of the times from a proactive point of view, you could actually get some of this data, a lot of it captured and all that, through a different model, not necessarily if it's not keyed in even at the hospital or transmitted, but other models can actually be able to allow us to collect.
Questions? Comments? Peer reviews? Okay, in the interest of time, we give them 1 second. Okay, we'll start with the ladies first. 1 second, closing remark.
Closing remark is that digital technology is brilliant and we can use it to advance the demand creation for health services, but also improving the quality of the services we offer, and also using data for decision making and especially around the public budgeting processes. So I think we need to embrace, but also at the same time to listen more to the people because they provide solutions, but also they provide the needs that need to be focused on.
So for mine, the digital, the AI, Internet of Things, machine learning, that's the future. For any solutions that we have to come up with, then we have all of us to be aligned with the future. And I believe that for the students who are taking this course, and I believe the vacuity is here in the development, there are so many opportunities within the insurance, within health, not only thinking with the health in service profession. There are so many areas. There is pharmaceutical drugs, transition, the supply chains. There is a lot of insurance there. There are a lot of machines used in this service industry. There are hospitals. There are opportunities with insurance. There are a lot of gaps that which needs advisory for these institutions. So the opportunities are huge, and I think the curriculum just needs to be enriched so that it can include all these areas. So thank you.
Okay. Kmtc. Niseme ama niwache? Technology. Haiwezi kuwa topic haifanywi. It has to be done. Because the market is expecting that you are coming to a space where technology will be used going forward. I think there's a question of how do you backpedal to ensure that your graduates and everyone else has the right skills to go into that particular space. Hospitals, in 2008, the highest transaction in banks was actually a balance inquiry. I'll repeat. In 2008, the highest transaction in banks was a balance inquiry. Why? Because everyone was queuing. People came up with technologies, including mobile banking. The first mobile banking we were doing was actually driving that balance inquiry to zero. And when we made it free for some of the banks that your balance inquiry, then we stopped seeing queues. People came to the bank to do more pertinent things, not balance inquiry. What are we saying to the hospitals and the institutions? We have to automate. What are we saying to SHA? We have to be able to go to that particular space where people can make inquiries without having to ever step. And how can you make it as convenient as possible? Please don't say it's only the MRI that you're buying. The other technology is what drives the business for your business.
I would say there is power in industry feedback. And I've been recipient every Saturday of a scorecard from Rufa. It started with an E, and it kept on climbing. I think now we are at B. That B is hard-earned, but it's because they give feedback. The challenge previously used to be You are given a knee and you're not told where to improve. Now you are given a knee and told where to improve. So I think I like that industry giving feedback to their partners to share. There is power in that because most of the time I think it's only health insurance whereby you pay to share head office, but you go to a hospital that is not share head office. And that's sometimes the paradox of health insurance. That's not where you go when you are sick. So the person with the feedback always most of the times tends to be the hospital or the facility and not the head office of that insurance that you paid your premiums to. So it's very important that there is acceptability of giving feedback, negative as it may be. The worst that can happen is that you ask for time and you'll be given the time. And I've seen how even for the consortium that we support, how that feedback has really helped improve things fast and also prioritizing a common known path so that we are not talking of very complex things that will take time. And in the meanwhile, we could have done better or the simpler ones that can improve access of healthcare services. Thank you.
Thank you very much, team of eminent personnel. God bless you.
Doc. I need to waste like 2 minutes. Because I have 3 students here who I will ask a question. Okay, I want them to share this question. Shall we just sit together, think of an answer? You're going to be our next panel 4. And as we waste those 2 minutes, have you ever heard about the Obama clap and the Obama wave? For the audience, have you heard about the Obama clap? For the panelists, moderator, have you heard about the Obama wave? You will receive it. Who remembers how Obama used to wave during campaigns? So almost 2 out of 3 no. Yani what percent? So we will start. Ladies first. As you walk back to your seat, just wave like Obama. And the rest, clap like you're clapping. I didn't say that. So yes, a proper wave. If you don't wave it, to your seat, to your seat. Now my students have disappeared. I waved them away. But Dr. Nyawira, you can give them those 2 minutes to just think out the question. And as they do that, I will also throw the question that I have asked them to all of us. We're talking health insurance. On the side of Kmtc, we are now teaching health insurance. We're going to have health insurance managers out there in a few years. For sure, we're rolling out the Social Health Authority, moving into social health from our previous members club, member contributory form of insurance. As stakeholders, and as a fan and someone very passionate about health insurance, let's think, how can we make social health insurance the 4th basic need to Kenyans? We talk about the 3 basic needs, what is taught in school: food, shelter, and clothing. How do we make health insurance the next basic need. Food for thought. That's what the young ones there are thinking about. And we can also try and think about it in our different fields. Let's target to make it the number 4. It cannot be number 4 and it's expensive. It cannot be number 4 and it's not accessible. It cannot be number 4 and it is not equitable. All of those. So in our different fields, we try and figure out how we can take it to number 4. So I thought we could get a number from the choir, but I'm told that one is, wako sawa. So our choir, you had prepared us for a dance and a song. And I think for information purpose, immediately after the choir and our students have their panel discussion, we will move into the last agenda for the day where we will be having the speeches. Then immediately after the speeches, we have the reading of the joint communique, and we will break for the day. So choir, karibu sana.
Yeah, in the morning we did a theme song about SHA, the importance of SHA and UHC, and what the government is doing together with the stakeholders. So we will repeat that piece. Thank you. Kmtc Kenya, cha kipekee cha afya Kenya. Kmtc Kenya, cha kipekee chaendeleza masomo kote nchini Kenya. Vitivo mbalimbali chaendeleza masomo kote nchini Kenya. Vitivo mbalimbali. Ukienda Nakuru, Kmtc yuko namba 1. Ukienda Mombasa, Kmtc yuko namba 1. Hata huko Hola, Kmtc tuko namba 1. Hata huko Lamu, Kmtc namba 1. Wauguzi wetu tunawapa heko kwa juhudi zenu. Wauguzi wote tunawapa heko kwa juhudi zenu. Washikadau wote tunawapa heko kwa juhudi zenu. Washikadau wote tunawapa heko kwa juhudi zenu.
Universal healthcare
inapatikana kote nchini Kenya.
Universal healthcare
inapatikana kote nchini Kenya.
Uvumbuzi wa SHA
unapatikana kote nchini Kenya.
Uvumbuzi wa SHA
unapatikana kote nchini Kenya.
Ukienda Nakuru
KMTC tuko namba moja.
Ukienda Mombasa
KMTC tuko namba moja.
Hata huko Hola
KMTC tuko namba moja.
Hata huko Lamu
KMTC tuko namba moja.
Chuo chetu
hongera,
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 oh, hongera,
hongera, chuo chetu cha afya.
Chuo chetu
hongera,
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 oh, hongera,
hongera, chuo chetu cha afya.
Chuo chetu
hongera,
kwa utafiti
hongera,
hongera,
hongera, chuo chetu cha afya.
kwa uvumbuzi
hongera,
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 oh, hongera,
hongera, chuo chetu cha afya.
na wizara
hongera,
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 oh, hongera,
hongera, wizara ya afya.
wizara
hongera,
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 oh, hongera,
hongera, wizara ya afya.
serikali
hongera,
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 oh, hongera,
hongera, serikali ya Kenya.
serikali
hongera,
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 oh, hongera,
hongera, serikali ya Kenya.
Ongeza kudani.
Mtu asimame. Kila mtu asimame sasa.
Washikadau, stakeholders, isn't it? Sasa leo ni siku ya kufurahia. Tukisema gonga buza, ukenya gonga buza, gonga buza, ukenya gonga buza, gonga buza, ukenya gonga buza, gonga buza. Kila mtu twende hivi. Gonga buza, ukenya gonga buza, gonga buza, nyagonga buza, gonga buza, Nairobi gonga buza, gonga buza, Nairobi gonga buza, gonga buza, Kmtc gonga buza, gonga buza, MTC gonga buza, gonga buza, MTC gonga buza, gonga buza, MTC gonga buza, gonga buza, mugeni gonga buza. Ukiitwa unakuja mbele. Mugeni gonga buza, mugeni gonga buza, gonga buza, mugeni gonga buza, gonga buza, hokeli 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 gonga buza, gonga buza, mwenyekiti 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 gonga buza, aho mogonga buza, gonga buza, principal gonga buza, gonga buza, principal gonga buza, gonga buza, principal gonga buza, gonga buza, wageni gonga buza, gonga buza, wageni gonga buza, gonga buza, David gonga buza, gonga buza, David gonga buza, gonga buza, Kaura gonga buza, gonga buza, Kaura gonga buza, gonga buza, Kaura gonga buza, gonga buza, gonga buza, Dakitari gonga buza, gonga buza,
dakitari gonga buza. He gonga buza, he dakitari gonga buza. Gonga buza, dakitari gonga buza. Haya mwanamberi sasa. He mwanamberi vayaye. Vayaye we. He mwanamberi vayaye. Vayaye we. He mwanamberi ni Kenya. Ni Kenya we. He mwanamberi ni Kenya. Ni Kenya we. Mwanamberi nesheko yero. Simama. Sasa watadansu mara 20 kwa sababu mnao. Asante sana. Thank you very much. Shangwe tena na vigelegele. Thank you so much.
A clap to the young ones, to the students. So today Kmtc is here launching a course and supporting SHA in the rollout of the Social Health Authority. But what is Kmtc without a student? Nothing. So they are stakeholder number 1. Our panelists. You can have the seats. So, the 3 of you, it was a joint. Have the seat. Choose whichever seat you want. She has gone around the seat like a professional. So, we posed a question. And I don't know if you decided to come up with one person with the answer or each of you with your own answers. It is up to you to now present to us your findings. You will introduce yourselves, what course you're doing, then tell us what the mode that you have agreed to use, and present your.
Good afternoon, everyone. My name is Brenda Waithera. I'm partaking diploma in health insurance management. So our question was, how can we make health insurance a basic need? So first and foremost, you can't insure against health when you don't know the benefits or the importance of your health. So first and foremost, you have to educate the people about the importance of health. You have to tell them how to prevent certain diseases, how to promote health, for example, by maintaining hygiene. Then you have to tell them where to get their health services. Yeah.
Good afternoon, everyone. I'm Emily Moreithi, taking health insurance management. Yeah, and I'm answering the question, how can we make health insurance a basic need? First, health insurance, you can make it a basic need. Okay. Okay, having an insurance is cheaper. For example, let's say you are sick, uende hospitali. If you have an insurance, it can pay for your bills. Lakini kama una insurance, you'll have to use your money from the pocket. So, health insurance, having it is cheaper.
Good afternoon, everyone. My name is Marlene Masawa, and I'm partaking health insurance management. and I'm going to answer the question, how is health insurance a basic need? So with health insurance, you're able to get peace of mind, and whether you are sick or not, you're able to be without stress. Yeah.
I think they deserve a better round of applause. They're students, and they have actually brought down what we have discussed since morning into 3 very simple things. First one, benefits, benefit package, know your health. That was, I think, panel 2. Then, health insurance is cheaper than out of pocket. Why are we doing health financing? Why are we all in this discussion here today? So very simple. Number 3, I think we should clap for her again. She has not asked, how will we make it a basic need? She has talked about it already being a basic need. And has also simplified it to stress-free, peace of mind. The simplicity. I think ketu tumeicomplicate na maisha. It is that simple. So a round of applause to the students. Though Dr. Nyawira will ask, gender inequality. Where did it happen? Anyway, a round of applause to the ladies. And as you may have your seats. Obama clap, Ama. Now, I will quickly invite Madam Asala to take over the next part of the session.
Thank you very much for the very good job done. Let us give him one. Let us give him one, and a better one, and another one. Thank you so much. So at this moment, I would like to invite the Kenya Medical Training College Chief Executive Officer, Dr. Kelly Oluoch, so that he can take us through the next session of the program. As he comes, we can give him the Obama ones. Let us give him the Obama ones as he comes, as he comes. We can do better. Okay, as he comes, until he comes, until he comes, until he comes, until he comes. Thank you very much. Karibu sana, daktari.
Thank you. We come to the end bit of this one-day conference, and it is the time for speeches. I wish to give the speech, the CEO speech. I'm Dr. Kelly Oluoch, the CEO, Kenya Medical Training College. And this is my speech. The Ministry of Health, represented here by Dr. Grace Ikahu, who is the Acting Director, Public Health and Sanitation, the Chair of the Board of Directors of Kenya Medical Training College, Mr. Josiah Cheriot, the representative for the CEO, SHA, Dr. Kahora, representatives of government and private entities, and private insurance organizations, distinguished guests, ladies and gentlemen. On behalf of Kenya Medical Training College, it is my distinct honor to welcome you to this timely stakeholder engagement forum. And today we convene to discuss a matter of national significance. That is, strengthening health insurance as a cornerstone for sustainable health care access in Kenya. Kenya Medical Training College has 97 years of experience in training human resources for health. The institution has presence in 45 of the 47 counties in Kenya, with 87 campuses and 6 satellite campuses. Today, Kenya Medical Training College has a student population of 66,807. We, as an institution, have 99 courses, which are divided in 18 departments and 7 faculties. Kenya Medical Training College produces over 85% of human resources for health for this country, and surplus get employment out of the country. As the key producer of human resources for health, we play an integral role in realization of the UHC and the bottom-up economic transformation agenda, particularly on human resources for health, that is critical for realization of the universal health coverage in Kenya. Madam Guest of Honor, over the past decade, the devolution of health services has marked a transformative era in our healthcare system, bringing notable progress in service delivery. Yet, despite these strides, many Kenyans still face barriers to accessing quality health coverage. This challenge underscores the urgency of achieving universal health coverage, a promise enshrined in Article 43 of Kenyan Constitution 2010. The Kenyan Constitution aspires to shield all citizens from financial hardships in seeking medical care. To achieve UHC, we must strengthen primary health care systems, enhance health financing mechanisms, and most importantly, invest in the training and development of health personnel equipped to manage emerging needs, including health insurance. The government's transformation from the National Health Insurance Fund, that is NHIF, to the Social Health Insurance Fund, that is SHIF, represents a key step in this direction. This shift emphasizes preventive care and the role of general practitioners in outpatient settings. To support this transition, Kmtc has been at the forefront of aligning its training programs with emerging healthcare needs and global trends. In addition, our extensive network of 87 campuses across 45 counties has positioned us as a critical partner in ongoing rollout of the Social Health Authority, SHA and SHIF. As part of this, Kenya Medical Training College continues to support 2 counties in the rollout for SHA, that is Kisumu County and Homa Bay County. The success of health insurance depends not only on robust policies, but also on skilled personnel capable of managing the complexities of claims and reimbursement processes. As part of our efforts, Kenya Medical Training College is proud to introduce a diploma in health insurance management, a pioneering 3-year program designed to address gaps in healthcare financing. This program equips graduates with essential skills to enhance the efficiency of health insurance systems, manage insurance claims, foster accountability in service delivery, and ensure that health financing mechanisms function effectively for the benefit of all Kenyans. The training program will ensure sustainability of SHA and SHIF by providing quality human resources for health. Further, we are in the process of finalizing a scheme of service for health insurance management personnel aimed at providing clear career pathways, recognition of prior learning, skills, and competencies, continuous professional development, and strategic deployment across national and county health systems. Our guest, the realization of UHC is a shared aspiration that demands collective effort. Therefore, we ensure the success of this initiative and the seamless adoption of the scheme of service for health insurance management personnel. We are committed to working closely with all key partners. I urge stakeholders to align policies that integrate health insurance professionals into existing health systems, mobilize resources to expand training infrastructure, and foster partnerships with institutions such as Kenya Medical Training College to sustain innovative health financing solutions. Your contributions have been instrumental in driving progress, and continued partnership remains a vital element to advance our efforts collectively. Our guest of honor, Madam, as I conclude, allow me to take this opportunity to celebrate a momentous milestone for Kenya Medical Training College. This year, Kmtc marks 97 years of excellence in training human resources for health, who have transformed healthcare delivery in Kenya and beyond. In line with this, next week, on Thursday, the 5th of December 2024, we will hold our 93rd graduation ceremony at Moi International Sports Center, Kasarani, starting from 8 a.m., where we will proudly release 21,261 graduates into the workforce. This is disintegrated into 509 higher diploma graduates, 11,478 diplomas, and 9,274 certificates. These graduates are prepared to drive Kenya's bottom-up economic transformation agenda and advance UHC through primary health care approach. I invite you all to join us in this landmark achievement for the college and indeed the country, even as we continue to work together to shape a healthier, more equitable future for all of us. Thank you. I now want to invite my colleague, the representative for SHA, CEO, to come and give his remarks. Karibu daktari.
Good afternoon. So, on behalf of the CEO at the Social Health Authority, mine is to thank the team for the active participation in this exercise and getting to know the feedback on the different pillars that we are expecting to support the drive towards universal health coverage in the country. We know it's not going to be an easy task. Then it needs the dedication of all of us, stakeholders at different levels, have everything interacting so that we can be able to achieve this. And as I mentioned earlier, it goes beyond the health sector. It needs to have an approach of the whole system. So So we appreciate the participation, we appreciate the feedback, and you're welcome to give even more feedback as things progress. We said this is entirely progressive, and it's expected to build and become better over time. So my appreciation, and thank you to all of you.
Thank you so much, Dr. Kahora. It's now my pleasure to welcome our board chairman to give his remarks.
Good evening. Let me start by introducing myself. I'm called Josiah Chiriot, Chairperson, Kenya Medical Training College. Let me also use this opportunity again to welcome each one of you to Kmtc. Anytime you feel you have an idea, our doors are open. Our CEO is here, he's always around to help and share information. We are present in all parts of the country. If you are in Mandera, we are also present. Lodwar, Lamu, you can visit those colleges and you will get assisted. The representative of the Principal Secretary, State Department of Public Health and Professional Standard, Madam Mary Mutoni, who is represented by Grace, Share representative, who has spoken, distinguished guests, ladies and gentlemen. On behalf of Kenya Medical Training College, Board of Directors, I welcome you all to this Stakeholder Engagement Forum. It is an honor to have key representatives from the government, private sector, and international organizations joining us today. Your presence here demonstrates a shared commitment to improving healthcare access and sustainability, a cornerstone of our universal health coverage agenda. With 87 campuses across the country, Kmtc is strategically positioned to ensure equitable access to health training, supporting the healthcare workforce during the training and after graduation. Our extensive reach enables us to produce professionals who are the backbone of healthcare service delivery at all levels, both nationally and internationally. I cannot explain further on that because you are aware we are one of the major stakeholders exporting human resource. Madam Guest of Honor, for almost a century, Kenya Medical Training College has been at the forefront of producing competent human resource for health. And this year alone, we are proud to be graduating 21,261 skilled professionals. At Kmtc, we believe in the power of collaboration to address Kenya's healthcare challenges. Kenya Medical Training College is a listening college. We listen to the demands of our stakeholders. We accommodate the views of our partners as Kmtc. Even in the new curricula or training that we are introducing to Kmtc and to the market, the insurance course. This forum is an opportunity to align our goals, share insights, and strengthen partnership for impactful outcomes. Guided by our strategic plan for 2023-2028, we have taken substantial steps to advance our institution and its contribution towards achievement of UAC. This plan provides a forward-looking framework to produce globally competitive health professionals by enhancing the learning experience, equipping students with special skills, and emphasizing lifelong training. As you are aware, 70% of the time spent by the students is done at the hospital or practical base. 30% is theory. That supports what I'm explaining to you. Aligned with the government's bottom-up economic transformation agenda and Kenya's Vision 2030, our strategy reaffirms our commitment to shaping healthcare training with focus on digital transformation and excellence. Madam Guest of Honor, as we look to the future of education, Kmtc, or Kenya Medical Training College, is leading transformative changes to enhance teaching and learning outcomes while supporting the rollout of social authority, SHA, SHIFT, and UAC goals. We are grateful for the support of stakeholders who have partnered with us in these areas. And we invite new collaboration to further this cause. This is our appeal to our stakeholders. We embrace your ideas. You are most welcome to call us, to write to us. As we address the theme of this forum, I'm pleased to highlight our diploma in health insurance management. Through this forum, Kenya Medical Training College is playing a critical role in building Kenya's capacity to manage health insurance systems that are accessible, efficient, and sustainable. In conclusion, Kenya Medical Training College remains steadfast in its commitment to transforming healthcare training and contributing to Kenya's development agenda. The Kenya Medical Training College Board assures you to our unwavering support in making these initiatives a success. Let us work together to achieve our shared goals for a stronger, more equitable healthcare system. Kindly let me repeat this, that let's work together. It's not only Kmtc, all of us who are present here and those who are not with us, that we need to work together towards these shared goals for a stronger and more equitable healthcare systems. Asanteni sana. Let me now take this opportunity to invite our guest to come and share with us our remarks and speech. Thank you very much, and God bless.
Good evening, all. I'm Jambo. As you've heard, my name is Dr. Grace Ikahu. I'm the Acting Director for Public Health and Sanitation, and I'm honored to deliver the remarks of our Principal Secretary, State Department of Public Health and Professional Standards, Ms. Mary Mudhoni Murioki, during this stakeholders forum on healthcare insurance. The Kmtc Board of Directors Chairperson, Mr. Josiah Cheriot, the Kmtc CEO, Dr. Kelly Oluoch, representative of the SHA, representatives of government and private sector, distinguished guests, ladies and gentlemen. Good evening once again. Universal health coverage is a key pillar of the government's bottom-up economic transformation agenda, BITA. It underscores our unwavering dedication to ensuring that every Kenyan, regardless of their financial background, has a right to healthcare that is accessible, available, affordable, and acceptable without financial hardship. This ambition calls for robust health financing mechanisms, including health insurance systems that prioritize the needs of vulnerable populations while driving sustainability in service delivery. The establishment of the social health insurance marks a transformative milestone in our journey towards achieving universal health coverage. Since its inception, over 15 million Kenyans have registered for SHA through platforms such as www.sha.go.ke and the USSD code *147#. These innovative platforms streamline registration and claims processing, ensure data-driven policy decisions, and ensure overall service delivery. Addressing challenges like login issues and payment discrepancies remain a priority as we refine these systems to improve user experience and efficiency. The success of sustainable healthcare access hinges on robust partnerships across diverse sectors represented in this forum. The Ministry of Health, under the guidance of the Cabinet Secretary, provides strategic oversight to ensure that health insurance systems are inclusive, efficient, and responsive to the needs of all Kenyans. The journey brings together a chain of partnerships, starting from the Kenya Association for Private Hospitals, the Association of Kenya Insurers, and the Rural Urban Private Hospitals Association, who play a critical role in expanding healthcare accessibility and driving innovation. The Kenya Medical Training College, who play a key role in bridging the human resources for health gaps, producing over 21,000 health professionals annually. Graduates from Kmtc are trained in essential skills, including claims management, fraud detection, digital health solution, ensuring that they are well equipped to support SHA and other health insurance initiatives. The regulatory bodies, such as the Kenya Health Professionals Oversight Authority and the Kenya National Qualifications Authority, also play a key role in maintaining high training and practice standards, producing health professionals capable of delivering on the goals of UHC. This forum therefore presents us with an opportunity to innovate and accelerate strategies to achieve this vision for all Kenyans. The theme, strengthening health insurance for sustaining healthcare access, reflects our collective commitment to achieving universal health coverage in the country. It echoes the need for collaboration in refining policy frameworks, enhancing technical capacity, and advocating for inclusive solutions that prioritize affordability and quality. Let us use this forum as a platform for generating transformative ideas, forging meaningful partnerships, and sharing best practices and identifying practical solutions to address pressing challenges. Together, we can collectively chart a path towards a healthcare system that truly serves every Kenyan. Thank you very much.
Let me again invite the guest of honor to give the communique on behalf of SHA and Kenya Medical Training College on the conference that we've had today. I also invite the representative of CEO SHA and the chair of the board to come up front.
Okay, thank you. I've been asked on behalf of all the participants of this stakeholders engagement conference to read this communique. I hope that this will be representing all your views. So we, the participants of the high-level stakeholder engagement conference organized by the Kenya Medical Training College, Kmtc, in collaboration with the Social Health Authority, convened to deliberate on strategies for bolstering health insurance in Kenya under the theme, Strengthening Health Insurance for Sustainable Health Care Access. The conference featured key discussions around 4 critical sub-themes, namely policy and regulation, exploring frameworks and policies essential for sustainable health insurance management, personnel capacity, health insurance management training and research. 3, expanding healthcare access, quality, accessibility, and affordability in the provision of health insurance for all. And lastly, digital innovations in health insurance by leveraging technology to streamline health insurance processes and customer experience. Key resolutions and commitments. 1, policy and regulation, recognizing the critical role of robust regulatory frameworks in achieving sustainable health insurance. Stakeholders committed to 1, reviewing and harmonizing existing policies to align with SHA reforms and UHC goals, strengthening partnerships between government agencies, professional bodies, and private sector to ensure compliance and accountability, and 3, advocating for inclusive policy development processes that engage all stakeholders, including the private sector and civil society. 2, personnel capacity, acknowledging the importance of skilled human resources in health insurance management. It was resolved to enhance training programs for health insurance management at Kmtc. Kmtc remains committed to training and development of human resources required to help the country to achieve UHC. The college is developing industry-responsive programs in health insurance to support the financing pillar of health systems, support the continuous professional development for healthcare providers and insurance managers, and to promote research and innovation in health insurance to inform policy and practice. Thirdly, under expanding healthcare access, we commit to ensure equitable access to health services. Stakeholders committed to the social health insurance remains committed to ensuring timely payments, enhancing service delivery, and building public trust through transparency and accountability, expanding coverage and reaching underserved populations, especially in rural and marginalized areas, addressing financial barriers by reviewing premium structures and enhancing subsidies for vulnerable groups, strengthening collaboration with insurers, healthcare providers, and development partners to enhance service delivery. And under digital innovations and health insurance, which was the last theme, underscoring the role of technology in improving health insurance processes, the following actions were agreed upon: investing in digital platforms for member registration, claims processing, and communication, enhancing digital management systems to support evidence-based decision-making, and addressing technical challenges and ensuring system interoperability to improve user experience. The call to action: we call upon all stakeholders, including government agencies, healthcare providers, insurers, and development partners to align their efforts towards the realization of an inclusive, sustainable, and efficient health insurance system.
Thank you. Thank you so much. I now therefore welcome Madam Marcella to then now lead us into the closure.
Thank you very much, our chief guest. Thank you very much, our board chairperson. Thank you very much, CEO SHA. Thank you very much, CEO Kmtc. We may now take our seats, even as I call upon Madam Carol Oyugi, who is our deputy principal at Nairobi campus, to come and move a vote of thanks as we move towards the end of this program. Thank you.
Thank you. Our chief guest, represented by Dr. Grace Ikahu, our chairperson of the board of Kenya Medical Training College, Mr. Josiah Cheruiyot, our chief executive officer, Dr. Kelly Olwoch, CEO SHA, represented by Samson Kahora, stakeholders who are present, both public and private, in your various capacities, good evening. Allow me to take this auspicious moment to pass our appreciation and to pass our sincere gratitude to each and every one of you for honoring our invitation and attending this stakeholders engagement. It has been a long day where we've been able to exchange views, where we've been able to learn, where we've been able to share, and more so, even we have been able to have some learning moments. At this juncture, allow me to first and foremost appreciate all the stakeholders who are present and who participated in the various capacities. We want to thank you so much for your engagement. We want to thank you for the ideas that you have shared, and we also want to thank you for your support for working with us. Allow me also to sincerely appreciate all the panelists and all the moderators for a lively session that we have engaged us in. Allow me to also appreciate our students from Kenya Medical Training College who presented various pieces in the entertainment. That is the Kmtc choir. We really appreciate that. Allow me also to recognize our ushers who have been able to support us, even in the registration and in the other support. Allow me also to appreciate the hotel, the Four West Sheraton Hotel, for giving us a conducive environment where we've been able to carry out our session. And last but not least, I want to take this opportunity to appreciate each and every one of you. We appreciate your presence. We appreciate your participation. And more so, we appreciate your engagement. And we look forward for more engagement. May God bless you even as we end the session. Asante sana.
Thank you very much. Thank you very much, Madam Principal. As we come to the end, allow me to call upon Madam Lilian Mumbi from SHA to come and give a word of prayer. Then we play the anthems even as we exit for our tea. Madam Lilian, karibu sana, so that you can bless us with a closing prayer for today.
Good evening, everyone. Let's stand so that we can thank God. Thank you, Lord, for this day. Thank you for a beautiful day that we have had. Thank you for the beautiful conversations that we have had. And even as we go back to your homes and to our offices, we pray for your protection. In Jesus' name we pray.
We are going to remain upstanding for the anthems.
Mungu yetu. Mashariki tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tulilinde, tuwajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. As the body we are endorsed to reach the sick, needy world. We embrace God-given chance, no more one with the goal. With constant growth in training and with service to all, we strive to make the world a better place for all. Marching on for excellence, to excel all the world. Whose commitment endeavors to mankind. Whose
Thank you, Victor. Thank you very much. We may now take our leave, our tea, coffee, chocolate, and everything else.